Hi, I'm Tom Myers. I'm the author of Anatomy Trains, and here we go on the next in our series of DVDs that tackle regions of the body and give you soft tissue strategies and techniques for those regions. We're not going through the basic techniques that you might get elsewhere. We're trying to go for more advanced techniques, but at the same time, we're trying to give you a fairly comprehensive way of looking into this. Obviously, we hope that you are well trained when you come in to use these techniques. We cannot be responsible for what happens if you use them, if you are taking them off a video. A DVD is a limited way of teaching. We're doing our best to get across all the aspects of the techniques, but please use them in good health and use them in such a way that your patients enjoy, your clients enjoy good health. Here we go. We're going to be looking at the feet and the legs, and we'll carry that all the way up to the hip. This DVD complements the pelvis DVD, which is the previous one in this series. What we're looking for here is covered in that wonderful English word, understanding. Understanding is a kinesthetic word, and the understanding, we're hoping you're having more understanding about the legs when we're done, but that understanding is a really kinesthetic concept of the legs being under you. And I really believe, I really experience in my practice that as you get people with their legs more under them, they come to more understanding. The other word that's commonly used, two other phrases that are commonly used here that I would like to put in from the language is grounded. We like people to be grounded, not ungrounded. That implies a certain balance of the feet coming down, not coming down just through the outside of the feet or just through the inside of the feet, but coming down on the feet. Grounded does not mean schlumped. Pronated feet, I call them hockey puck feet. They just kind of slide around on the ice and they're not really grounded. A really grounded foot is a prehensile, slightly prehensile foot. We have been talking, or are going to talk about the yield and push that goes on, and that yield and push involves a little bit of grip with the feet, and that grip helps hold up the arch, and we want that prehensility in the foot, a little bit of grip in the foot. It has to do with grounding, not just schlumped down on the ground, but poised on the ground. The other phrase that you hear in the language a lot is light on your feet. And light on your feet is another thing that we want to see here. People, so grounded and light on your feet are two almost contrasting notions, and it's hard to have both at once. I once watched a master. He was not a Tai Chi master, he was a Sufi master. He walked into a room where there were 250 of us packed. I mean, we were packed knee to knee in this room. I don't know, maybe there were 400 of us anyway. It was a huge room and everybody was seated cross-legged. It was back in my spiritual times. We were getting ready to meditate. Here comes this guy across the room. He's going to sit in a chair in the front of the room, but he has to cross through this room full of people. I have never seen anybody walk with such a combination of being absolutely grounded. With each step, he knew exactly where his foot was going to come down. He knew exactly how his support was going to come down onto that foot. And yet at the same time, he was very light on his feet. We expect dancers to be light on their feet. But are they also grounded? We expect martial arts people or Olympic lifters to be grounded. You have to be grounded to be doing these activities. But can they also be light on their feet? It is a conundrum of legs as we look into this. It's a koan of how do I keep groundedness and still stay light on my feet? That's certainly you find people who are at one end of the spectrum or the other, and we're trying to bring them towards the middle of that. But I wanted to bring those three concepts: understanding, which is having your legs under you; grounding, which is being able to connect down from your upper body through your legs to the ground, but being at the same time light on your feet, which means aware, awake, and differentiated in your legs enough to make those slight adjustments and quick adjustments to whatever life throws your way in terms of balance, surface underneath, changing surfaces underneath. I work on a boat a lot of time, and the boat is constantly shifting under your feet, so you have to be both grounded and light on your feet. At least I hope so. So this is primarily a technique DVD. We can't avoid, in fact we don't want to avoid, having some strategy considerations in here, but we can't cover all of the strategic considerations for all the situations that you're going to encounter in terms of high arches, low arches, pronated, supinated feet, flex knees, hyperextended knees, etc. We do have webinars, books, and other ways. This is primarily going to teach you the techniques that you can use. We will have some of the strategy considerations. The goals, however, are a right-left balance, obviously, between the two legs, and a good alignment of the hip, knee, and ankle. And we would like looking at the body from the side to see that the foot and the lower leg are under the upper leg and the pelvis. In other words, an alignment in through the coronal plane. And that is the goal toward which these techniques are being applied. So if we look at these two gentlemen, we can see, for instance, that the legs on the right side are knock-kneed, or genu valgus, and on the left side are bow-legged, or genu varus. And however this might be looked at in the physiotherapy world or other worlds, if we looked at it from a fascial guy wire postural point of view, the alignment would be such that we would be looking at where is the tight bowstring. So here you can imagine on the left side a bow, an easily bowed piece of wood with elastic on either side of it. And if I bend that piece of wood, then the fascia, the elastic band on the concave side of the bend is going to get shorter, and the fascia on the convex side of the bend is going to get longer and tighter. So the word tight isn't very useful. I want to know, is it locked short or locked long? Is it concentrically loaded or eccentrically loaded? Usually concentrically and eccentrically loaded refers to muscles. I use locked long and locked short for the fascia. So if we look, we could see that in the gentleman on the left, the inside of the leg would be locked short, and the outside of the leg would be locked long or loaded eccentrically, and that where you want to work, even though he might be complaining of iliotibial band syndrome or bursitis on his greater trochanter, you don't want to work on the outside of the leg. Where you are going to get the good function is to work on the inside of his leg. The opposite applies to the person on the right. The person on the right has genu valgus, the knee going in, and that would mean that the bow, if you look at the bow would be going from hip to knee to ankle like this, which would mean the tightness, the shortness, tightness is not a word I want to use, the shortness is on the outside of the leg, and the tissue on the inside of the leg is that which is eccentrically loaded. So it will be tight. He may be complaining, as overweight people often do, about the medial collateral ligament on the inside of the knee. But what the work that we really want to do on a fascial basis is on the outside of his leg. In other words, to open up the short part of the bowstring. In this person, we can see the same kind of idea with the bow legs, or genu varus, the O legs as we tend to call them, again would be short on the inside of the leg, even though they may be tight on the outside of the leg. So more of the techniques that we're going to be doing with the deep front line would be indicated, more of the techniques with the adductor muscles and their fascia from the pelvis DVD would be indicated, and not so much, even if the pain is on the outside. I guess this is just an argument that we've been making for a long time. As Ida Rolf used to say, where you think it is, it ain't. Or as Eric Dalton says, don't chase the pain. So you have to look, and somebody else, I don't know who said this one, is lengthen the short before you strengthen the weak. So lengthening the short in this case means the inside of the leg. In these people, you can see that the legs, we've included the upper body, so that you can see that the upper body and the legs are obviously intimately related. You can see the differences in the right-left, for instance, in the gentleman in the middle, and how his right leg is supporting him and how his left leg is supporting him. And the same is true of the lady on the left or on the right. On the right, the legs are more balanced than the upper body, so would we find an effect in the legs of the imbalance in her upper body? I think so, but it's a little more subtle, a little harder to see. Let's think about the human leg as opposed to the animal leg. The first thing that we'd like to say about the human leg is that it starts at the 12th rib and goes down from there. So let's just look at that, at the skeleton for a moment. If you look over here at the skelly, the quadratus lumborum starts from the 12th rib. The psoas muscle starts from all of the lumbars, but right up here on the 12th thoracic vertebra, or the first lumbar vertebra, and comes down. And these are the first muscles of the leg. So it is more proper. We talked about this a lot in the pelvis DVD, and we're not going to cover this part of it. We're not going to do it again in this DVD, but we do need to understand that as we look at the leg, that it starts from here and includes this bone. The division between the axial and appendicular, between the fish skeleton and the limb skeleton, comes here at the SI joint. And this bone here could be considered to be part of the lumbar ribs. It's as if the lumbar ribs came down and formed the hip bone. That's not exactly true embryologically, but it is metaphorically true. And it really is true that neurologically, myologically, and embryologically, the leg grows out of the lumbar spine. The sacrum, yes, it attaches itself to the sacral spine when the hip bones get formed in this ring of bone that you can see here, but the hip bones are part of leggishness that starts here at the 12th rib and goes down. We're going to be concerning ourselves more with what goes on south of there as we look down the leg. But I do want to make that point first, that the leg starts at the 12th rib and the 12th thoracic vertebra, and that walking proceeds from that TLJ, from the thoracolumbar junction, that T12L1 junction that is kind of the body's universal joint, if you think about it. We will, however, leave what we've done in the pelvis DVD, and we're mostly going to go on and talk about the feet. But the leg in human evolution is an interesting subject. In fact, all quadrupeds have the same muscles and bones that we do, pretty much. There's a bit of a difference, but not much. But the difference for us is that we took the hip, which is very flexed in the quadrupedal position, somewhat flexed in the primate position, and we really opened up that hip to full extension so that the spine and the leg are in the same line, and the head, chest, and pelvis are over each other in a way that they are not. You can argue about kangaroos and penguins if you want, but human beings among the primate line have the most extended hip, and the leg is gravity resisting. It is, instead of being crouched, which would be what Dwyer would call the sport position or a ready position, or if I were going to get in the starting blocks, I would flex my legs. But when I'm in my standing position, the legs are extended, the hip is extended, the knee is extended, the ankle is in neutral, and that kind of alignment is what we're going to be looking at here. So we've come a long way since our ancestors who had more hand-like prehensile feet, as you can see in this slide, and we now try to put them in shoes like this, so as we wander around the city streets. So it's no wonder that we got a bit of problems with our feet, but understanding the human foot, which is really quite a unique invention of evolution, is worth our study. Well, let's look at the leg as compared to the arm. In the arm, we have something which is really based on mobility. The shoulder is the most mobile joint in the body. The scapula, not on this skeleton because it's screwed in, but the scapula moves all around on the rib cage. You can't do that with the leg. The leg has to transfer weight from the foot, which we're going to have a lot of discussion of later, from the foot to the lower leg. But you can see that the tibia goes straight into the femur and the femur goes straight into the hip. The weight is carried straight up from the foot to the hip in a way that makes it good for yield and push. In terms of fundamental movement patterns, the leg is better at yield, give in a little, and push away. Legs are designed for that. Legs have been designed for that since salamanders first had them. And arms do better with reach and pull. Arms do better in tension. So reaching up and pulling down with the arms. We see that again and again. If you look at this slide, you can see the yield and push on the left side. As somebody keeps their balance, they have to come down into the foot and push off to take the next step. And kind of a unique way of using the legs in reach and pull fashion, but not very many people strap themselves to a tree and hang upside down, unless you're Batman or something. But what you see in our human history very much is the yield and push and reach and pull in the arms and the legs, like this boy climbing the tree. For one thing, we can see how much dorsiflexion he has. We'll be doing that dorsiflexion test, and you're not going to see as much dorsiflexion in our models, even though they're in very good health, as you see in this boy's foot, because he has been climbing those trees forever. And so you see the arms with the reach and pull, and the legs with the yield and push. That really is an important thing to understand, that the legs need to be able to yield and push. That's how the design of the ligaments and the muscles work, as you will see. We start walking from a very early age, not that early. It takes us a year. This baby has got to be a year old in order to start walking on those feet. Up until then, the bones aren't ossified enough, the muscles aren't strong enough, the brain isn't coordinated enough. It takes a very long time for us to do the act of standing. I was about to say the movement of standing. Standing is Tadasana. Standing is standing still. It doesn't seem like a movement, but it is a movement. It is a postural movement to get up there and stand. This skeleton has a rod up its bum and a stand so that it can stand up. Your skeleton doesn't do that on its own. It needs coordination from the muscles and the nervous system in order to do that. And the development of the legs is the subject for another webinar or something that we'll do. But just to give it now this idea of evolutionarily, we came from a bent leg and a very flexed hip to a straight leg, and embryologically we start with very weak, very unossified legs, and we have to develop that strength over a year before we're ready to stand and walk. But at that time we have great potential in the legs. It's just the fact that we misuse them, misuse the feet by putting them in shoes, we misuse the legs by sitting a lot, we get nicks and dings and bangs over the course of our sporting life or our childhood life or our automobile life that interrupt the good functioning of the legs. And those are the kinds of things that we're going to be trying to work with here. Your feet offer you a great support. They are wonderful supports. Look at this. That set of feet is holding up two people in a very strange position, and they work just fine if we let them. Sometimes we put our feet in situations where they are really not capable of holding up what we're asking them to hold up on stiletto heels or very strange shoes. Sometimes some people have put on such strange shoes that they seem like they're trying to hurt themselves. This is the shoes of a fakir in India, where he is standing, literally standing on a bed of nails. And that is a way of subjugating the body. It is not, however, something that I recommend for you. The other ways in which we have treated feet culturally, these are Chinese woman's bound feet. And there's an x-ray of her feet on the right. That is standards of beauty across the world differ from place to place, but this involves either really bending or actually breaking the bones of the feet to achieve this tiny foot look, which was fashionable in China a while ago. Feet are capable of many things. These Samburu warriors, I took this picture in Africa in 1979, I think. These are the Samburu jumping, and they just are jumping from the ground. They are not taking preparatory, they're not even taking a preparatory deep bend before they come. They're just springing off their feet. And look at how high this is going. And all of those folks are 6 feet tall or taller. They're very tall people. And it's because they have those long shanks and they have the long Achilles tendon that they are able to create the bounce that comes into that kind of dancing that's common to the Maasai and the Samburu. Finally, before we go on to the feet, it would be negligent of me not to mention the fact that they are reflexes all over the feet. This is one of those new agey ideas that you have foot reflexes all over the place and that they go to these different organs. The idea, that at least it was as it was given to me in the 1970s when I first learned this stuff, is, oh, you have 70,000 nerve endings in your feet and those nerve endings go to the organs. That is crazy. You maybe have 70,000 nerve endings in the feet. I don't know. I haven't counted them. But you certainly have a lot of them, and they have a lot to do with your balance. But the what I certainly have found, and I don't know about this as a treatment method, I certainly had wonderful reflexology sessions in my life, and I keep finding reflexes on the feet. And those reflexes really do seem to correspond to areas of the body being mapped out roughly as it is on this chart. There's lots of different charts for this in the hand. I have no idea of the mechanism by which this works. I really can't comment on whether it works as a treatment method, but I must say that it works quite well as a diagnostic method. If you really understand these, the map of the feet, and you make allowances for the individual person, it really does work. I don't know why, but boy, I've never had an alcoholic where if you press the pituitary point, you can't put them through the ceiling. It's like a needle through their big toe. And other people with constipation, they will have reflexes in their large colon that, again, send them through the roof. And I actually came across this first because I kept noticing, this was in the 1970s when I first started my practice, I kept noticing, I was doing massage, I was doing some reflexology along with my massage, and I kept noticing women that on the inside of the heel, they would have a point that would really, really be terribly, outlandishly sore. And to a woman, these were people with the old intrauterine devices, which were called copper 7s, and they actually worked by irritating the lining of the uterus. Probably not a good idea, and the new IUDs work on a different principle altogether. But these were irritating the lining of the uterus, and their uterine point was always sore. So I've used the foot reflexology as a diagnostic tool for a long time, and I'll leave you to judge whether it's a good treatment tool or not. We already commented on the idea that the arms are more for reach and pull or more for use in tension, and that the legs were better at yield and push or more for compression, for resisting compression and pushing away. But I wanted to talk about a similarity between the arms and the legs here. If we look here, you can see, of course, we have the collarbone and the scapular bone, which would correspond to the hip bone and the pubic bone down here in the pelvis. But please notice that in the arm we go one bone. The next section of the arm is 2 bones. The next section of the wrist is 3 bones. The next section of the wrist is 4 bones. And then the hand itself is 5 bones. And that 5 bones goes on out. Actually, mammals tried 6 and 7. There are mammals that had 6 and 7. Actually, I've had cats with 6 and 7 toes. It's kind of a throwback to that evolutionary time. But mostly, most of us stop with 5. There are occasionally children born with an extra finger, which is usually removed surgically. Very shortly after birth, and most mammals have come back to the five-fingered idea. Even a horse and a pig starts out with a five-fingered hand, well, a five-fingered paddle, but by the time a horse is born, all of these bones have folded down into the third fingernail. When you look at a horse's hoof, that's the horse's third fingernail. When you look at a pig's cloven hoof, or a camel's cloven hoof, that's the second or third fingernail. We keep the five-fingered hand. We just open the skin in between. We disappear. We actually kill. They do their apoptic gene, and they commit suicide, the cells between the hands, so that you don't have skin between your fingers. Those who are born with skin between their fingers or between their toes, again, it's usually surgically changed as soon as they're born, so you don't see it so much as you did when I was young. But that's not that they grew extra skin, it's that they didn't take the skin away between the five that comes here. But anyway, 1, 2, 3, 4, 5. Wait a minute, there's 8 carpals. Yeah, but this bone right here, this pisiform bone, as you can see, it doesn't really sit in the carpals. It sits outside, and it's a sesamoid bone, like your kneecap, inside the tendon of the flexor carpi ulnaris. So it's not really in this 1, 2, 3, 4, 5 section. Why am I spending so much time on the arm when we're talking about the leg? Because it's such a similar structure in the leg. We have the hip bone, as we talked about before. We have a ball and socket joint. We have one bone. We have the knee, which we're going to talk a lot more about, but it's basically, get this right, a hinge joint. And then we have 2 bones. Then we have another hinge joint. And then we have 3 bones, the calcaneus, the heel, the talus, and the navicular. So 1, 2, 3, and then if you look down at the top of the foot, 4, 3 cuneiforms and a cuboid, and then 5 again. So this basic structure of 1, 2, 3, 4, 5 is common to both the arm and the leg, but in the leg, as we've seen, it is more designed for stability. The weight goes straight from the foot to the top of the foot, into the tibia, into the femur, into the hip. That's a much more varied pathway that the arm takes, which we'll talk about when we do the shoulder and arms techniques DVD. But enough about the arms, on to the legs. So the goals of having the hips, knees, and ankles aligned, we can see here in looking at these 2 ladies from the front that we might have some issues with alignment along the sagittal plane, but let's look at alignment in the coronal plane. Here we can see this woman who looks actually fairly aligned from the front. If we look at her from the side, we can see that the lower leg is really behind the upper leg, and we're going to be doing techniques to bring that into alignment, and having an alignment between the hip, knee, and ankle from the side. Many, many people, including this person on the right, if you look, have it set up so that the pelvis is anterior to the ankle. Now, I'm not talking about whether it's anteriorly tilted or anteriorly rotated, as the physiotherapist would say, but whether it is simply located, the hip joint, anterior to the ankle. And in this case, it really is. In fact, in both cases here, it really is. So we're looking for that, the grounding, the calm, the lack of anxiety, let me put it that way, that comes from having that hip, knee, and ankle aligned from the side. We are a very anxious culture. We have that in our language too. It means getting on your toes. If you want to get ahead, you got to get on your toes. So that whole thing is in the culture, it's in the language about how we get ahead of ourselves. And part of what we're looking for here is to line the body up so that it can sit back into itself and find its being rather than always being forward in its doing. That is the meaning of this postural work, is to bring the body back to its place of home, its place of being. And that involves bringing the alignment from the side as well as the alignment from the front. So you can see here that the more the leg is aligned, the less muscular activity is involved in keeping it there. Obviously, even just the spring in the ligaments and the fascia that's represented by the picture on the left is enough to keep you present, keep you there and stable in a leg that's balanced. The more that the hip goes in front of the ankle, which is happening a little bit in the middle picture, that's going to take up your the deep posterior compartment, or in this case they're showing the peroneal compartment is going to get very tight, which absolutely happens. And then if you really go forward, if your hip is very forward of your ankle, you're going to start using up the soleus muscle and even the gastrocnemius muscle. If you see somebody who is really where their pelvis is very anterior to their feet, and you test them, test the standing tonus of their soleus muscle, you will see that it's very, very high. You're not going to sort out that tonus by working on their soleus muscle. You're going to sort out that tonus by taking them from looking like the right side of this picture and getting them to look more like the left side of this picture. We'll be giving you techniques that will be going in that direction, but you understand that whatever technique you use, that's the goal, lining them up. This goes right down to the ankle. If we look at it, we're looking for a neutral ankle. We want the dorsiflexion or plantar flexion not to be too great or too small. I would say that the person on the left is fairly well aligned, fairly well in that neutral place where the knee is above the ankle and the foot is 90 degrees from the angle of the lower leg. If you look at the person on the right who has hyperextended knees, that ankle is chronically plantar flexed, right? Remember, doesn't matter whether the foot moves on the lower leg or the lower leg moves on the foot. The action at the ankle is still either plantar flexion or dorsiflexion. You will see people who are chronically in plantar flexion or dorsiflexion. So we have a test of how far people can go into dorsiflexion, and we also want to look at just where they end up standing so that you can understand what their needs are in terms of the ankle, because hyperextended knees are not just hyperextended knees, they are plantar flexed ankles and probably hyperextended hips as well. God gave us, your mom gave you, Darwin gave you, I don't know, whoever you want to believe in that's responsible for this shape, 28 bones in the feet. Now, 14 of those bones are in the toes, and we are going to look at those bones when we get into the first part of the techniques. That leaves another 14 bones in this part of the foot. We tend to think of the foot as a solid tetrahedron, a solid tripod with the talus at the top and the base of the first metatarsal and the base of the fifth metatarsal and the heel as the triangle on the bottom. So it looks like a tetrahedron, it looks like a tripod. However, there are all these bones in here. We just described how we expect those bones to unlock and relock every step that you take, but that's part of the design. Certainly, they are held in place by the ligamentous sleeve that goes around all this that we'll be talking about, and it's absolutely supported and moved about by the muscles coming down from the top, which we're going to talk about in terms of the anatomy trains right now, and then we're going to talk about them much more specifically as we get into how the lower legs support the arches later. So we see the hinges in the hands. There's 2 layers, and actually in the toes there's 2 layers, but it's functionally like one hinge. And then we see that the ends of these bones are rounded, so this is actually a rotational joint. And so we're going to show you an assessment of how the rotation of this joint goes, how people roll from the inner part of the foot to the outer part of the foot involves rolling in these metatarsophalangeal joints, or MTP joints, and they can function as a hinge as you're walking, all 5 of them together, but each of them separately operates as a rotational joint. In other words, multiple degrees of freedom. Abduction, those people who are trying to spread their toes apart, either with those toe spreaders or in their yoga class just doing it. And so those joints abduct and adduct, as well as flex and extend, and a little bit of rotation or circumduction around that joint. So it's a multiple degree of freedom joint. Look at the next one. Look at these bones. They're very square-ended. They don't allow rotation. You can't rotate. Well, I can in this one because it's all made out of loose stuff, but this is all put together, and this is a hinge in the middle of the foot. We'll talk about releasing this hinge for people with high arches, or what's called a high arch pattern. Then you have the rotation of inversion, eversion. That is a multiple degree of freedom joint. We'll have more to say about this in a little bit. I just want to get this alternation because the upper ankle joint is a hinge joint. And then between the tibia and fibula is a rotational joint. That rotation takes place below the knee, and then the knee itself is a hinge. The body uses hinge movement or linear movement along with rotational movement. And what happens when you put a line together with rotation? You get a spiral. So almost all human movement that you can see involves a spiral. A kick is a spiral, a hit is a spiral. You can see the spiral in my trunk even to support the hit. Running is a spiral, walking is a spiral. Spirals are put together by combining these hinge movements with the rotational movements, the hinge movements with the rotational movements, the hinge movements with the rotational movements. This idea of the alternation of hinges and rotations is really essential to my understanding of human movement. I'm really glad I got this information. I wish this information was more readily available, and now you have it. Okay, you've been very patient working your way through all the anatomy that I wanted to make sure that we had. It's, for me, of course, the anatomy is very important. If you understand what's under your hands, you have a much better chance of making the kinds of changes that you want. So I hope that part's been helpful. Let's get on to the techniques themselves in the next section. Hi, I'm Tom Myers. I'm pleased to welcome you to this next in our DVD series of aligning the feet and the knees. And here to help us to be models for the techniques for you to see are Daphne and Sampat, and I'm very glad to welcome them and thank them for giving up their time to allow you to see all these techniques. Hope it's helpful. Okay, we're about to do a test here in terms of the arches. You hear a lot about whether arches are high or low, whether the foot is pronated or supinated, and I am really less and less concerned. Part of my lack of concern is having been out in indigenous cultures where you can find people with really flat feet who are very functional, and they walk a lot every day, and they do just fine without arch supports. So the question to me nowadays is not whether your arches are high or low, but how responsive are they? And I just want to give you this idea from this foot that is very bendy because the joints are very loose, that as you step, that there are a series of essential events described in James's book, but we're just going to talk about the feet and legs part of this today. As the heel strikes, because the heel is offset, it's not right under the tibia, is it? It's a little bit to the outside. So when you land on your heel and the weight of the foot is coming down and the ground reaction force is coming up, the reaction is for the talus to fall off the heel, for the heel to turn medially, and the talus to come off it. When the talus comes off of it, it turns slightly medially and acting like the head of a screwdriver in the slot of the screw. So the talus into the tibia fibula, as the talus turns, it's going to turn the lower leg medially, and that has a series of chain reaction events up the leg, which are worth discussing when we get to the rest of the leg. But right now, I just want to see how this is happening in the arch. As this turns, as the talus falls off the calcaneus, the foot unlocks. The arch drops. As you roll through and you put the pressure on the top, the flexor hallucis longus muscle that comes right through here, and just the mechanics of the foot as well, turn the foot back into supination and lock the foot so that when you press off, you are pressing off with a nice solid foot into a nice solid ankle, for reasons we'll talk about in a bit, and right up the cruciate ligaments of the leg because the knee will be extended, right into the ligaments of the hip because the hip will be extended. In other words, driving all the force from the foot up to bringing the torso forward. This idea of the responsive arch as opposed to what is the position of the arch. Do I need to support this arch up or do I need to let this arch down? In the extremes, that's worth doing. But in the middle, I'm much more interested in, is the arch responsive or is the arch not responsive? Here's a test by which you can check not the position of the arches, but the responsiveness of the arches. I used to worry about how high or how low the arch is, and certainly if you have somebody with really, really supinated feet, as we discussed before, or somebody with really, really flat feet, you might want to help change that. And we'll be talking about that in terms of the muscles that come down from the calf. What I'm concerned with is, are the arches moving? Are they responding? Are they going into the pronation that I expect them to go into as she glides onto the foot? So she takes the step. Yes, there's the arch coming down onto my hand, and as she prepares to take the next step, just let your weight go into the next foot. And do I feel it supinating and coming off? And I do. So if you want to exaggerate that, you could take a step way behind you, even sort of turn behind you a little bit. Yep. And then turn in front of you, put your foot right up here. Yeah, so that way I get and go way back and way forward, and that way I get a really good dynamic test of the arch and its strength I can feel in my hand and its responsiveness I can feel in my hand. The only way that tests like this make any difference to you, make real sense to you, is if you do them with 50 people, 100 people. So the next bunches of people who come in that you're working with their feet, just do this test and you'll say, first couple of ones you'll say, I wonder if that's what he meant. I wonder if this is a responsive arch. But by the time you've done it with 20 or 30 arches, you'll know exactly, because some arches will be stuck. And it doesn't matter whether they're stuck down or stuck up. Stuck is not great for arches. Arches want to be responsive. So do it once again, and I feel the response coming down, coming up, coming down, coming up, as she weights the foot and unweights the foot. Okay, so once again, now with Sampat doing the same test, I just take my fingers around so they're comfortably into the arch, and the rest of my palm on the top of his foot. And Sampat, just take a step through, if you would, from behind to in front with your right foot. And come back again. And even make it a bigger step. Step over here a little bit more to the front. Good. And then step behind. Good. So I feel the same thing that I felt. Well, this is a different foot, so we'll do it this way. But as he steps onto the foot, the arch dynamically, the leg turns, the arch dynamically goes into a bit of a pronation. And as he begins to step off, the foot comes back and locks up into supination again. So it's this responsiveness of the arch, the slight responsiveness of the arch, not whether it starts here or whether it starts here that's so important, but is it responsive? Does it move when the weight comes onto it and move back as the weight comes off? So that's what I'm feeling for. As he takes a step forward, go ahead, does the arch come onto my hand and then come off of my hand as he comes back? Great. So I'm feeling the arch come down, come up again, the pronation of the supination of the foot. And that really is a much better test of the functionality of the arches than just saying, oh, are those arches high or low? Were his arches higher or lower than Daphne? I don't know. That's not really what I care for. I've seen people in indigenous cultures, lots of people in indigenous cultures, with no arches, flat feet, and they've been walking all their lives and they do just fine. It is not the position of your arches, regardless of those people who are trying to sell you arch supports. It is not the position of the arches, it's the dynamism of your arches that's important. Okay, oh, these wonderful movable skeletons. It's hard to get the joints all right, but for the purposes of this test, what we're looking for is when he goes up on the balls of his foot and rolls that joint that we already said was a rotational joint. What happens to those joints? Do they roll in the way that we'd like to see them roll? So this one rolls more than a real human skeleton because it's put together with elastics. I hope your foot isn't that loose. I hope your foot isn't that loose. But let's come up on the ball of your foot, lift your heel up off the ground, and now roll to the outside of your foot and to the inside of your foot. And so those of you at home looking at the camera, you're looking down at his foot. I'm looking at it from the side. But can you see how he rolls over the foot? He rolls more easily to the outside. It doesn't roll so easily to the inside. But again, these are not the kinds of tests that you're looking for a specific thing. You're looking for this compared to everybody else that you do, just for fun. Put your right foot back and put your left foot forward and see if there's a difference in what happens when you roll this way and this way. In both cases, we kind of get locked up rolling to the inside. So that's where focusing. This movement is an inversion, eversion at the subtalar joint. But what we're looking for is the rolling at the MTB joints, at the ball of the foot. So what kind of rolling's going on there? A little bit restricted on the inside, not much restriction on the outside at all. Let's see that with Daphne. Okay, so once again, we're just going to see what happens with the foot with an inside-outside roll. So pick up your heel and go from the inside to the outside. And you're going up where this foot's really coming off. Is it easy to roll and keep this on the ground? How far can you roll keeping that on the ground? So we really see that Daphne's foot is different from Sampat's. We have no judgment here about who's better or who's worse, but I do notice that, boom, she can't really roll to the outside toe without the big toe coming way off in the front. That's interesting. If you go higher with your heel, does that make it a little easier? Not much. That big toe still wants to come up really early in the game. That might be something that we could ease out. If you turn your foot sideways, just go to ballet position, you see how she has a higher arch, so the foot is more locked in supination, so that as she tries to go on rolling onto the outside, having that roll in that part of the foot, boom, the big toe has to come up. Let's see the other foot. Is it the same? So rolling inside, rolling outside. That one can stay on the ground longer. Can you feel that? Mm-hmm. And so this is a test that I want to see. How much adaptation is there in the foot to this medial and lateral roll, which is actually a complicated motion. I don't know if we can take the camera back to show her whole leg in this, but if you'll see, there's an inner and outer rotation of the hip that shows up at the kneecap. And then because her knee, if you flex your knee a little bit more, you can actually get some rotation of the lower leg. And then there's inversion, eversion at the ankle, and that all ends up down here at the adaptability at the ball of the foot as you are adapting to left-right motion during function. So that's a test that's worth doing to see what kind of mobility you have in the foot, both in terms of the arch that we just did now and in terms of the MTP joints that we just looked at. Okay, so let's begin with Daphne's feet here. I always like to get to know a foot before I start doing anything with it in terms of how it's moving. We'll break this up specifically as we go. We already saw that on this foot, eversion was a little bit of a problem, and I can feel that in the tarsum of the foot, but
that's for the future bits. First thing we're going to do is say hello to her toes.
There are just so many things you can do with feet. We're not going to do them all. We're just going to do a few of them. But a lot of people have incipient arthritis in the feet, and a lot of people put their feet in leather coffins or prisons for the feet all day, namely shoes. Not this woman, however. What I would like to invite you to notice is that you can take each bone of the toe. As we noted earlier, these first two joints are hinges. Only one joint in the big toe, and the rest of these joints in the small toe are hinges. And what I'm inviting you to do is to slide the bones along the hinges like this. You can slide them up and down, but they won't go that far that way, and you'll get the most relief from sliding them left and right. This was taught to me by an old physiatrist. There aren't too many physiatrists left in the world, but a physical medicine doctor, and it is one of the most effective things I've found for irrigating the toe joints and reducing the pain of arthritis that happens here. So sometimes you get one joint, sometimes you get two. In most of the folks in the second, third, and fourth toes, you're going to have two joints, this distal interphalangeal joint and the proximal interphalangeal joint, the dips and the pips. In the little toe, sometimes there's only two bones. Yep, she's only got two bones in her little toe. So what I'm doing is stabilizing one joint, one bone, in this case, the proximal interphalange with the intermediate phalange, and sliding them back and forth across each other. This irrigates the cartilage on the surface of the joint, breaks up tension in the ligamentous sleeve around the joint. Every once in a while you'll get a pop when you do this, kind of like a chiropractic pop, but that's not the object of the game. The object of the game is this kind of ability to translate the bone on the top from one to the next. And this is more difficult here, so I'm going to do the up-down part. Anterior, posterior, superior, inferior, I don't quite know the word, but I'm holding the proximal bone and wiggling the distal bone. Here's what I'm not doing. I'm not doing this. Wiggling the bone back and forth, bending the bone back and forth on the other one. I am translating it sideways, translating it sideways, translating it sideways, one bone on the other. Now, you can see how much more movement I've got in this foot due to the color of the toenail polish, as opposed to the amount of movement I've got here. So, you should have your toenail polish farther up your toes. I don't think that's it. I think that these joints are more fixed in Daphne's foot, and that I'm going to spend a bit more time going up and down and right and left, superior, inferior, and medial, lateral, in order to get those joints to really move on each other. It's worth it to spend some time here, because later on in her life, her joints will feel better if they've got more of that motion. And of course, one of the more important is the big toe joint. So I'm stabilizing the proximal bone, moving the distal bone back and forth on it. And since this joint is subject to gout, subject to more arthritic conditions than almost any other joint in the toes, I'm going to, with this hand, stabilize the metatarsal, and with this hand, move that bone on top of it. And again, I'm going back and forth, front to back, and back and forth, side to side. I definitely want to have that happen to these hinge bones. We'll be doing other techniques for these joints here, but this one at the base of the big toe, I apply the same technique to the base of the toe that I did out in the toe itself. Stabilize the bone, move the other bone on it. Great way to irrigate the joints of the toes and have them be nice. So just so you can see this on another foot, that we are moving the distal bones, finding where that joint is. Oh, he's got a long bone here. So grabbing the proximal bone, moving the distal bone back and forth on it. For people with sore toes, this is really helpful. Getting the toe joints lubricated, opened up, and not all squidged into shoes. Okay, so we're finding this one is a little bit less mobile. So I'm making sure my leverage is good and just getting that one bone to move on the other. Sideways like this. Not bending like this. Sideways like this. Now, a second technique. This is not a structural technique, but it's a really great reflex. We talked about the reflexes and a way to open up the foot. Perhaps you've seen those foot spreaders. Here's a woman who does yoga. Look at how those toes spread. I could put one of those yoga toe spreaders, which were, of course, invented for putting toenail polish on, but got incorporated into an alternative practice. Lots of people are doing that. And this isn't even hurting you, is it? No. It would be hurting me if you were doing it to me, because my toes aren't as spread out as yours. That's a really nice bit. But if they're not, one of the things you can do is to put a finger right down at the base and go into the tissue at the base of the toe. Spread the toes, come in, and open up the webbing at the bottom of the toe. It's a great reflex point. If somebody says to you, oh, my sinuses are opening up, that's because these are reflex points to the sinuses, but I'm not doing it for that. That's a special added benefit. If your sinuses open up, that's your tough luck. We're just trying to open up the toes. She has such open toes anyway that this is not the most necessary technique in the world. So our next journey up here is to make sure that the metatarsals are differentiated, having worked with the toes. So this is her fifth metatarsal from here to here. So I'm going to hold the base of the fifth metatarsal and I'm going to work the upper part of it relative to the fourth toe. So I could be holding the base to make sure that the base is moving, which the base is moving in this case, or I can be holding the fourth toe and slide these past each other. Again, the motion is this way. I'm not trying to bend the foot this way. That's not a bad thing to do if you want to open up the bottom of the foot or reinforce the distal transverse arch that we talked about. But really what we're trying to do here is differentiate this metatarsal from the fourth and the fourth from the third. See how I'm just sliding it up and down, and the third from the second. Oh, that hasn't got so much movement in it. That's good. That's the way it's supposed to be. There will be less motion between the third and the second, but between the second and the first, you usually have quite a bit of motion. Very good motion here all the way along the metatarsals. So we'll just have you put your foot up for a sec, and we'll just check it out on the other foot. And looks good. This is somewhere between a test and a technique. If there is reduced motion, but I'm not finding any reduced motion except the reduced motion that I expect between 2 and 3. If you remember, 2 and 3 are the extensions of the tibial ray coming out. In other words, this part of the medial arch. So this is somewhere between a test and a technique. You can start it out as a test and have it turn into a technique, because I'm just checking how is the motion between number 5 and number 4 at the distal end, and between number 4 and number 3,
and between number 3 and number 2. And I have that reduced motion between number 3 and number 2 that I expect, but a nice motion at number 1 there. But all in all, really good motion at the distal part of the transverse arch here. So that kind of differentiation from this end, remember that this end is rounded and this end is square, so we're expecting a kind of hinge-like motion here, and we're using the hinge at this end. So the other way to do this is I check the hinges by putting my hand over the bottom and I move this bone. Yep, that's moving fine. Yep, that's locked up the way it should be. Yep, that's moving. Yep, that's moving at the distal end, and here down at 5, well, we saw that on the other side of the foot here. Yep, 5 is moving. Okay, I just want to make sure that we get the motion right on this. So Sampat, take a hold with your thumb and your upper 2 fingers on the end of that bone, and same deal with the next bone, and then wiggle in between. There you go. How much motion do you have in there? And they're going straight up and down relative to each other. That's it. Now move along one bone. And if you do that, can you feel how there's less motion there?
Yes.
It's harder to get those guys to move on each other. That's the way it should be. That's the way it works in the foot because of that long second metatarsal bone doing a key lock up into the cuneiforms. So try the next one. I think you'll find it more movable. And I think everybody can see, and I'm just going to reinforce it, that it's it's a hinge-like motion of one bone being taken past the other like this. Similar to what we were doing in the toes, a little bit different because of the way the ligaments are arranged. And this is not really a joint between these two in the way we think of synovial joints. And then do the last one, that little toe, that should be movable. In all the people except those who really put jam their toes into those pointy little Italian shoes with the very nice little pointy ends to them, but they're not great for what they do to toes. But Daphne's toes are in great shape.
As we finish the toes and the outer joint get to the bottom of the foot proper, it's always a great idea to warm up the bottom of the foot first. The foot reflexologists tell us there are 70,000 nerve endings in the feet. I kind of accepted that on faith. I don't know how many nerve endings there are in the feet, but I do know that your feet are, of course, very important to your understanding, to your ability to balance. The bottom of your feet, your hip joints, your jaw joints, your eyes, and your inner ear are the 5 major ways that you know where you are in space. So having good awareness on the bottom of the feet is a good thing. So just warming up, I'm just using my thumbs to warm up the bottom of the foot. Great preparation because we're going to be tackling tough tissues inside the foot. There's no doubt about it. And those techniques can be sensationful. Now, there is no way around this. There is not much muscle around the heel. There is skin with nerves in it, and then there's fascia, and then there's bone. So you are reaching through the skin and the nerve layer to get to the fascial layer over the top of the bone. And therefore, this can be painful. So the thing that I would like to make very clear is that what I'm using is the flat of my finger, not the knuckle. It's going to look as if I'm using my knuckle, but I'm using this whole flat of the finger. That way I distribute the pressure and that makes it easier. We'll show this to you on both sides so you can see, but what I'm doing is putting my thumbs under the heel, putting these bones against the heel, and then coming down along the heel. And we call this 0, 45, 90 because we do it 3 times at 3 sets of degrees. So the 0 is 0 degrees parallel to the floor. My thumbs are under the heel. My knuckle bones are along the edge of the heel. And I'm going to pull that tissue down from the top of the heel bone
down to the corner of the heel. The corner of the heel bone, remember, as we saw before, is a ½ inch off the floor with all that padding that is supporting the heel up off the floor. So the corner of the heel is only down this far to the corner. So I'm pulling down. Again, I wouldn't be doing this because it puts his cruciate ligaments into full extension, but just to show you. And to show the position on the inside, we'll just do it with this foot. You can just stand that up, that's great. So it's the same deal. My thumbs are along the bottom, the flat of this knuckle. All I have to do is just turn that knuckle in there and he's going to wish he were somewhere else because now I'm pressing with a very sharp knuckle on the heel. If I keep it the flat of the bone, then I can do this, and it's still what we call in our world sensationful, but the idea is to minimize the awful sensation and to maximize the freedom of the heel. This is especially a good technique for those whose heel is jammed into the ankle, as we saw in the assessment part that we did earlier. So I would definitely be using these techniques to free up the heel. So now I've gone to 45. My thumbs are still under the heel and I'm coming from just behind the ankle, but I'm leaving about a ½ inch, 1.25 centimeters, for the nerves. The tibial nerve coming through there, peroneal nerve on the outside. I don't want to get that, so I'm leaving just a little space. My thumbs are still under the heel and I am pulling, grabbing the tissue between me and the heel and pulling it down to the corner of the heel bone, which remember is a ½ inch, even more right here, off the floor. And then finally 90, 0, 45, 90. 90 is going to go along the hedge of the heel bone. If you come down here and you do this last bit of this technique on the fat pad under the heel, you will do nothing because this is very, 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 very tough. They've been walking on it for their entire life and they haven't squeezed it out from under their feet, so you're probably not going to do it with a stroke or two. So for this 90 one, I'm going to come in from the side. My thumbs are going to go on the back of the heel. I'll just lift this up so you can see it. And I've got the same deal going on the outside, and I'm now using the pressure between my thumb and my fingers to bring the tissue back along the heel. Now that heel bone is a ½ inch off the floor, so I'm a ½ inch up to where I can boom, 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 feel the edge of the bone underneath my knuckle. And I'm doing exactly the same thing on the outside. Now I'm doing the 90 degree. I don't care what you think of which is 0 and which is 90. This is 0 compared to when they were standing up, but it's 90 compared to the floor now. 45, again, I'm going to leave a little space for the peroneal nerve. No twanging of nerves necessary in the making of this video. And taking it to the corner of the heel bone, and likewise starting just a little bit up on the Achilles tendon, coming down onto the heel bone, bringing that tissue towards the corner of the heel. Now, how could he be helping during this? I wanted you to see this in stillness so that you could see the finger position. But now, if he dorsiflexes while I'm doing this, any one of these techniques, the 0 or the 45 or the 90, anything along the heel, that's going to help. Yep, come back down and then lift it up. And the idea is you're pushing the heel towards me. That's it. Anything that he can do, and relax, to help drop the heel out of the lower leg, drop the heel towards the floor, the imaginary floor, drop the heel towards me. All that's going to be helpful as we get this heel to free up. And now if you do that foot wringing idea, you'll feel that the heel is getting freer. In fact, what I feel is that the heel is not quite free enough along that inside edge. So I'm going to add this. This is just for Sampat because I want to get that particular tissue because it's so tight. Now, can you lift your toes up sometime? I could take and put him on a different position on the table. This is down and dirty, a quick way of just getting this extra tissue that was so tight, getting it down to the corner of the heel bone there, because then, yes, then when we work the heel, we have something that's much looser and more functional. Good idea. Now I think we're ready to go to the lower leg. So if you look at Somfat's feet from behind, you will see that his heels appear to be under his body, and that's good for support. But if you remember the part that we did in the anatomy, you'll remember that the heel is actually offset. If the weight is coming down through the tibia, it comes onto the talus, and the heel is actually set a bit to the outside. That would appear to be a design flaw, but it is actually part of the design of what happens when your foot hits and the talus turns like the head of a screwdriver in the slot of the screw and makes the whole leg respond, and then boom, comes back up again. That's what we were testing when we did the arch test back at the beginning. But the heel then can, see if I can do this in such a way that the camera can see it. So the heel can tilt medially, it can tilt laterally, it could rotate in. I know the heel's going out, but the front of it's going in, it's rotating in, or it can rotate out. So when we did the 0, 45, 90, when we did the heel release on the table, we were just trying to release the heel. Now we're going to do it standing up in a loaded position, and when it's in a loaded position, we can actually help with some of these rotational or tilting problems that happen with the heel. So let's see how we can do that with our fingers. So it's quite possible to do the 0, 45, 90 in standing in a loaded position, and I want to do that first and then add some variations. And then I really think we really will be ready to go to the lower leg. You just keep finding more things to do. So if I put my thumbs behind the heel and I put this whole bone against his heel bone, and now I get you, Sampat, to please take your knees straight forward. Same thing we did in the dorsiflexion test. And I feel what happens to his heels. I could be, that's fine. Plenty. Don't go so far that your heels come off the ground. That's great. Come on back up. So it's a question of going forward slowly and coming back slowly. So go forward slowly. We watch what happens to his heels. His heels are in pretty good shape. You can see them pulling in just a little bit, but not much, and they're not tilting much. But we're going to imagine that they do. So the standard practice would be, I'll just mock it up, coming along at 0 degrees, coming along at 45 degrees, coming along at 90 degrees. We can do that same thing standing up that we did. I'll just do one in actuality so you can see it. Okay, Sampat, just go forward with your knee, stretching out, and I'm going to keep the heel coming back as you go forward, and then come on back again when you get to the limit, and then go forward again. So this is the coming along the bottom edge of the heel bone, bringing it back towards the heel. But if he were tending to tilt in, if he were tending to medially tilt or pronate his foot, then as I came back, I would want to lift on the inside and drop it on the outside. So go ahead and go forward with your knees, and I'm going to keep him from going towards his predilection by lifting the inside and dropping the outside. Go ahead, lifting the inside, dropping the outside. Good, come back. Now on this side, you really can see that when he goes forward with his knee, watch my fingertips, go forward with your knees, is that this finger goes forward. My finger on my left hand gets hauled around. You can actually see it when he's standing there, that the tissue is hauled around this way. So I want to go not what I was doing before. I want to come back with my inside hand and forward with my outside hand as he goes forward with his knee. So I'm taking the tissue forward on the outside, backward on the inside. Good. And I can even combine that, coming up on the inside and down on the outside, but back on the inside and forward on the outside. In other words, I can get this done as quickly as possible because it is sensationful. It's even more sensationful when the foot is loaded like this for many people. Come on back up again. But this allows me, I'll just show you with my fingers what I'm doing, in case it's hard to see with the knuckles, of coming down and forward on the outside and up and in on the inside. Now, if his tendency was to go this way, I could do it the opposite way. Come up and back on the outside and down and in on the inside, but with him tending towards pronation of that heel and tending towards a lateral rotation of that heel, that's not what I want. What I want is to take him in the direction of balance when I'm doing this. So you'll have to judge which way you're going to go with your fingers as they move by what you see happening with the heel, either when they're standing there or when he goes into a knee bend. So go into a knee bend again. Ah, good, that's staying without going forward so much. That's pretty good after only one application. I might try to make a living doing this stuff. Okay, go ahead, go forward and come back. It's working that way to bring his heel around. Let's try that with Daphne's heels and see if it looks the same. Okay, so here we are with another set of heels. Let's just see what happens when Daphne goes forward with her knees. They crackle and come on back up. The heels stay pretty grounded. Just do it once more. Let's have a look. But you can see this heel being pulled around. In fact, both heels are being pulled around to the front. Come on back up again. Okay, so while I might warm her up with the 0, 45, 90, so go ahead forward and back up again. Good, and now I go up to the ankles, but I leave a little room for the nerves, and come on down again, avoiding the endangerment sites in behind the malleoli, just coming down to the corner of the heel bone, and come on back up again. And then again, not going too far forward, just starting on the tendon sheath of the Achilles tendon, which we'll get to later also, and coming down onto the heel bone as she moves the tissue away. So that's all without the variations. That's just the straightforward 0, 45, 90 technique for freeing the heel from above, freeing the heel from the ankle joint, and freeing the heel from the forefoot. But if I wanted to make a variation, because she tends to wrap around to the front, I want to bring this tissue, I want to bring the tissue back where I think it belongs. So go ahead forward with your knee, and I'm going to keep her heel from doing that lateral rotation. I'm going to keep the tissue moving, and come on back up again. Keep the tissue moving in the direction that we want, and go forward again, and come back. So I'm coming back with my right hand, forward with my left hand, and I'm always using a big surface of bone, of my own bone, on her bone in order to reduce. So this one, if we look, we can see how the Achilles tendon is coming down and then out. Do you see the change in angle of the Achilles tendon right there? So that means the heel itself is falling to the inside or medially tilting. So on this side, just to show another variation, I'm going to lift on the inside and drop the outside. So once again, my dear, if you could go forward with your knee and come back, and I'm doing two things. I'm holding the heel in the position I want it to keep, which is a little more laterally tilted, and I'm bringing the tissue in the direction of that. Go ahead forward again. And I'm bringing the tissue in that direction because that's where we want to see it go. All right, try again, going forward with both knees. Yes, that's tilting less. Knee's not popping any less, but the heel is tilting less. We still got to do some work with this Achilles tendon, but it's getting better. Let's just do this. So one more time, coming forward. And I'm really holding that tissue into where I want it to go, and then come back up again slowly. And she's glad I'm stopping.
So I think you can see from this picture that the arch can be considered part of the back of the body. Certainly if we thought of a four-legged creature, this sole, what we call the sole of the foot, would be part of the back of the leg. And in this ballet dancer, you can see that the arch of the foot corresponds to the arch of the knee, and if she were standing up, would correspond to the arch of the low back and the neck. We've talked about that before when we've discussed the anatomy trains lines in other contexts. Right now, we just want to see how the bones contribute to the arch. And when we say arches, we want to make sure that we understand that arches are made, not born. Nobody is born with an arch. There's a suggestion of an arch in a baby's foot, but the arch really comes into being when the baby stands up and starts to walk on it. It actually starts as the baby starts to crawl and to push on the legs, but it really comes into being. It's the last one of your secondary curves. Your cervical curve comes in, your lumbar curve comes in when your cervical curve comes in when you roll over onto your belly. The lumbar curve, secondary curve, comes in as you sit up and crawl. The knee curve comes in as you stand up, but the arches don't really come in until age 2. After a year of walking, you have strengthened the muscles of the lower leg enough to create the arches. We're going to be using that same kind of idea, the strength and the balance in the muscles of the lower leg, to see how these arches work. But let's look at how the arches work or don't work, as you can see in some of these cases. So, if we look at the foot, the 14 bones of the foot really divide themselves quite neatly down this line. You can see in the slide, it's colored differently, and I'm holding it here and putting my fingers between a division that goes all the way through the foot that divides what's known as the tibial ray from the fibular ray. By ray, we mean ray of development, but you're going to see this in terms of force transmission. So the force transmission from the tibia goes to the talus, from the talus to the navicular, from the navicular to the 3 cuneiforms, from the 3 cuneiforms to the first 3 toes. So that's a pretty natural division of the foot. Tibia to talus, talus to navicular, navicular to 3 cuneiforms to the 3 metatarsals. That's the medial arch, or the toe foot, or the tibial ray. Depends on whose language you want to use. Heel foot and toe foot is dancer talk. Here's the heel foot. The heel going into the cuboid, going into the 4th and 5th metatarsal, the gray one in the slide. But you can see how those are really different. And this is connected more with the fibula. And in developmental terms, these guys come out of the same embryological thrust that's giving you the fibula, goes into this 4th and 5th metatarsal, cuboid, and calcaneus, whereas these other bones really are, as you can see here, a direct push down from the tibia. That makes this outer arch an outrigger on the canoe. It is not the main way you take your weight, and the outer arch is not the main way you take your weight. The medial arch is the main way you take your weight, and the outer arch is like the outrigger on the canoe. It is like the balance beam that keeps things. If you want to see this, this is really simple. Go right up on your toes now. Stand up wherever you are and stand up on your toes and feel that you are standing much more on the first 3 toes than the last 2. And if you don't believe me, then just stand up on the last 2 toes. See, you're losing your balance. I'll bet you almost everybody
will have very much less balance if they're standing on their outer 2 toes than they will if they're standing on their inner 3 toes. This is the weight bearer, this is the outrigger on the canoe, this is the balancer. So if this takes the lateral arch, and this is the medial longitudinal arch, we have 2 other arches, or parts of the canopy, if we want to consider it that way. Sorry about these toes, they just won't straighten out. We have the transverse arch, but there are 2 transverse arches, the distal transverse arch and the proximal transverse arch. If we look at the distal one, we see that nothing in the shapes of the bones holds that distal transverse arch. It is really easy for this to fall, and if people have calluses under the 3rd or 4th metatarsal heads, they have lost their distal transverse arch. They will somehow survive and maybe even thrive without this arch. It would be better if they had the strength of the muscles and the tissue to hold that arch up. Here you see the distal and the proximal transverse arch. The difference in the distal one is that the bones easily change, and it's really up to the soft tissue under these bones to lift this up. If we look at the proximal arch, which goes across the foot here, this is the number 4 in our 1, 2, 3, 4, 5 thinking. 1, 2, 3 cuneiforms and a cuboid. If we look at the 4 here, the proximal transverse arch is much stronger. This is held in place by ligaments. It's held in place by the shapes of the bones. It's really hard for this arch to fall unless you jump out of an airplane without a parachute and really hit the ground hard. Then you might bust your foot to the point where that transverse arch would be damaged. But this transverse arch is commonly lost with people, and it really is not a matter of manipulation or problems with the bones. You can have a Morton's toe, that kind of thing, where things have disarranged themselves. But the best fix for a distal transverse arch problem is to grip, grip, grip with the foot. Take a towel and grip, take jacks and pick them up, take stones at the beach and pick them up. All of those things are going to help create and maintain this transverse arch. Coming on to our next part, we're looking at the subtalar axis. That is UU in this picture, going not straight along the foot. What I'd like you to notice is the axis of inversion and eversion, which is the subtalar axis here, is not straight along the foot. You do not turn your foot in this way and this way. You turn it in this way and this way, with the axis going across the foot from outside the big toe, inside the big toe in the front, to outside the heel in the back. That is the axis of this joint, the subtalar joint, the joint between the talus and the navicular and the heel. It's really important to understand that the ligaments of the ankle gather in 2 joints. The subtalar joint, and that's the one that gets strained in an ankle sprain, and the tibiotalar joint, which we'll talk about in a minute. We're talking about the subtalar joint in a minute. So you can see 4 tendons in this picture. The 4 tendons are located in the 4 quadrants between the UU line, which is the line of inversion and eversion, and the OO line, which is the line of dorsiflexion, plantar flexion, which could be the lower leg working on the foot or the foot working on the lower leg. It's still dorsiflexion and plantar flexion. Any tendon that exists on this side of the OO line, on the front side of the OO line, is going to be a dorsiflexor. Anything that is posterior to this OO line, like the soleus and gastrocnemius, obviously, are going to be plantar flexors. But it's this subtalar axis, this UU axis on the slide, that we really want to understand. Anything that's on this side of that line is going to be an inverter, and anything that's outside that UU line is going to be an everter. This does go some way to explain why we do all of our body reading about we do all of our assessments about the arches while the person is standing, while they're loaded. Because when you unload the body, if you look at this line, I'm going to hold it up in a different angle, and you realize that the line, the UU line, the line of the subtalar joint, the axis of it, is going from here to here. And therefore, the muscles that attach to here, the soleus and gastrocnemius, are what? Inverters or everters? They're inverters because they lie on the inside of that line. So gastrocnemius, but soleus especially, has so much residual tension in it, you've got it on all the time that you're standing up, that as soon as you lie down, boom, you become an inverter. Your foot is inverted. Most people who lie down on the table, their foot inverts. Why? Because that big strong muscle, which has residual tension in it, is an inverter because it's on the inside of this UU line. I just can't tell you how many people seem to have the idea that inversion and eversion goes straight along the foot. It doesn't. It goes along from the inside of the front of the foot to the outside of the back of the foot. And therefore you can understand just by looking at this and understanding where all these tendons come down by the ankle, what they're doing in terms of inversion, eversion, and plantar flexion, dorsiflexion, which is, of course, what we need to balance the arches. We've been talking about inversion and eversion, that UU line, as if it was the foot moving on the lower leg. But of course, the foot could be stable and the lower leg could be moving on the foot. So that's one thing I want to look at when people are coming in. So I'm having them do what you see in the picture here, which is to keep the foot on the ground and then see how far they can go into pronation and supination, or inversion and eversion. In other words, how much this subtalar joint is able to move. So let's take a look at that test. I know we're looking at our right foot here, and this is Sampat's left foot, but get over it. It's all right. We're just going to test inversion and eversion, but we're going to test it by moving the body on the foot instead of moving the foot on the body, which we'll do when we're on the table. So just to test functional inversion, we're going to have him take his right foot as far away from this foot as he can, and then bend his knee. Now, you see how that outer arch is lifting up off the floor. So you got to come back until that outer arch is on the floor. Now, keeping that outer arch on the floor, how far can you take that down? I'll get my hand out of the way so people can see. Nice inversion. Very good. All right, and come on back again. And then, how would we test eversion? How far can you come? So step behind yourself with your right over this away. How far can you come over that away before the front of the foot starts to come off the ground? You see, not very far, right? There isn't nearly as much eversion as there is inversion, and not very much before that big toe starts to have to come up off the ground, right? So that's how much eversion he has functionally, foot on the floor, to the ability to stabilize the leg on the foot. And we already saw how much inversion he has. All right, so let's switch feet for fun. Okay, now it's the same foot. You're gonna have to step over me and step really out to the side and see how far you can go. Really nice, very, very good inversion. From the point of view of the martial artist, all right, come on back up again and then step behind yourself over that way. How far can we go and still keep the big toe on the ground, especially the ball of the big toe on the ground? Not very far. That's how far the eversion goes. But it's going to be less. It's going to be less in everybody. In fact, let's try somebody else and see what it looks like. So if we put Daphne through the same test, if I ask you to really take a long step to your right and then let your knee go ahead and bend over there until you feel this outside arch is coming up off the ground. Actually go that far to where, yeah, now I can put little fingers in under the outside arch, so that's no longer, that's something happening in the hips. It's not any longer happening in the ankle. I want the foot to stay on the ground. How far can she go? Go ahead. I'm going to hold your foot down this time. And that's about it. It's going to get hauled up if she goes any farther, but that's really good. All right, come on up. And then stepping behind yourself, let's see how far you can go into eversion. Well, better than and worse than is not a thing to say, but just because comparisons are useful for teaching, not for judgment, but useful for teaching, we'd have to say that she's got more eversion than Sampak did. Okay, and let's try the other foot. Okay, you can step by me here to get that. Yep. There you go. Inversion, plenty of it. She can go way down and the outer arch is still staying right on the ground. No problem. And step behind yours. Come on back and step behind yourself. And let's just see how far the eversion goes. A little bit farther. Come on. Can you take that knee out? Nope. If she goes any farther, that's going to haul that medial arch up. So a little less eversion on this foot than she had on the other one. But I really prefer to test it on the ground because that's functional inversion and eversion. When we sit on the table and have them invert and evert, it's not loaded. So when it's not loaded, you're not getting an accurate representation of how that ankle works. So let's, in terms of dorsiflexion and plantar flexion, we want to notice that the talus is wider at the front and narrower at the back. So here's the surface of the talus on the back. Here is the surface of the talus on the front. It's wider. What does that mean? That means when you go into dorsiflexion, you're locking this bone into the opening between the tibia and fibula because the widest part of the bone is spreading out against the opening provided by the tibia fibula. And when you're in plantar flexion, that there is more looseness in this joint because the narrower part of the talus is in the joint. This makes a lot of sense in very many ways, one of which is if I'm jumping across a stream, I'm going to jump from the dorsiflexed position. I want my joints locked so that the force of plantar flexion starts right up the leg and projects me into the air exactly the way I want to be. But now on the other side of the stream, I'm landing, oh, there's leaves there and sticks, and I don't know exactly what I'm going to be landing on. I'd better be adaptable, so I land in a plantar flexed position where the foot is adaptable, and this joint, this tibiotalar joint, the upper ankle joint, is loose and can adapt easily to whatever surface it is I land on. Have you ever jumped across the stream and you did land on a root and you landed in this dorsiflexed position? You don't like it because this bone is locked into the joint in a way that is not comfy bumpy. You want yourself to be landing in this plantar flexed position so you have that adaptability. So what happens, and we're going to see an assessment about this in a second, if you go into dorsiflexion and this gets locked, we expect to see the tibia move out and up a little bit. So we assess that in terms of, does this move apart from each other when the foot goes into a strong dorsiflexion and the wide part of the talus comes in? Does it spread these bones apart? And in point of fact, what should happen, what can happen, is that the fibula goes out and up just a little bit, out and up and down and in. If you feel the out, you're doing pretty well. If you feel the up and out, then that person has a very adaptable joint. The up and out is because of the direction of the fibers in the interosseous membrane that you can see here. It's a double-layered membrane, and because of the way that the fibers are directed, you get this motion of the tibia and fibula with each other if there's enough mobility in the body and if there's that responsiveness inside the body. That's what we're testing for when we do this test to check about the tibia and fibular malleoli moving apart from each other in dorsiflexion. So relative to what we were talking about before with the talus and the tibia and the fibula here,
it is much better to test this motion in standing. We'll test it on the table as well, but functionally testing it in standing is much better. So if I get Daphne to bring her knee forward towards me, both knees actually, and see how far can she go. What is the angle in dorsiflexion? Yeah, and she is doing the right thing with her upper body, which is not tucking her tail back like a rooster, but slightly tucked under like a Tai Chi master. Go on back up again. And so we watch the dorsiflexion at the ankle as she comes forward with both knees. Is the tibia sliding on the talus? Is the talus sliding back? One way I can tell that is to put my finger, I hope you can see it, on the back of her heel, and she comes forward with her knee, and do I feel the heel coming back into my hand, which I do. Very slight, it's a millimeter, you can't really see it, but you can feel it, and come on back again. And that's a good thing that the talus is working as normal. Let's just have you turn 180 degrees and we'll just see the other leg, just in case it's different. So go ahead forward. I'm feeling the heel coming back. Yeah, there's a little more compensation in this foot, but boy, that's good dorsiflexion. You would be a good tree climber. Come on back up again. Let's compare that with Sampat and see what kind of a tree climber he'd be. Okay, so Sampat, I'm going to put my finger just gently on the heel, and you bring both knees towards me. Because if they just bend one knee, it doesn't work so well, because twists the pelvis all up. So what we're really looking at is what's happening in dorsiflexion here. How far can the knee come down? What kind of angle can we make between the lower leg and the foot before the heel comes up? Because if you come farther, you'll feel that the heel comes off the ground. Keep going down. Yeah, you'll start taking the heel off the ground, and that's not an accurate measure. So we just want to see how far it goes without that. Come on back up again. And turn the other way, and let's just see how it looks. Okay. However, I do want this foot not to be turned out, so we're going to keep it straight in and keep your knee going straight over your second toe. And how far can you dorsiflex? A little more limited on this side compared to the other side, but still working pretty well. So go ahead, come on back up again. If you see a limitation in this test, one, they're going to be having trouble with squats, but secondly, you're going to want to be working on the superficial back line and the deep posterior compartment of the deep front line, which we'll be showing during the techniques. So I don't remember when we did the test which ones of Sampat's feet was more difficult to dorsiflex, but this one qualifies. It's a little bit of difficulty in dorsiflexion. And what we want in here is talar glide. We want these, the talus to be able to glide in the mortise and tenon of the tibia and fibula, coming around it like that. So here's the talus inside gliding. So what we're trying to do here is to get the talus to drop back in the joint as we go into dorsiflexion. So not just going into dorsiflexion like that. The talus is not gliding back in the joint. You watch the heel, you will see the Achilles tendon coming closer and closer to the ankle. I would like to see it drop back now. And we're going to see a visible drop back with just one application of the technique? Probably not. But if I put my hands on the fibular and tibial malleoli, right on the outside behind it, not way inside behind it, that's where the nerves are. They're going to feel the nerves. But if I am supporting, I'm just holding up the leg by means of the medial and lateral malleolus on my thumb and forefinger. I'll show you the thumb on this side, just right in behind the malleolus. That allows me to push the foot through the joint. So I'm then going to, having held this up, I'm going to take the foot. Now the reason I don't really want to hold it up is, I'm going to hold it up for the camera, but I really wouldn't do this in practice because I don't want his knee in hyperextension. But just to show you, taking the foot and dropping the foot down through
the joint in at the ankle, dropping the talus down through the tibia and fibula joint while I hold the tibia and fibula with my other hand. Now, I'm actually going to do that on the table so that the knee is relaxed and flexed. Same deal though, holding the tibia and fibula with one hand and dropping the foot back down through. Okay, now once I've done that passively, I can ask him, now go ahead, Sampat, and dorsiflex. Bring your foot up and the heel down. Because I want him to retain this, and the way that this gets retained is that as the toes go up, the heel goes down. If the heel is jammed into that ankle, the toes go up and the heel doesn't move very much. It isn't his problem really, so you can see his heel moving down. But you will have some people for whom the ankle is so close to the heel that they don't get much motion of the heel at all compared to the forefoot. So I want to make sure as he's doing this, so your toes come to you and your heel comes to me. Push that heel right out away from the ankle. Lovely. And push the heel away from the ankle. And now I'm going to drop that talus down. Push the heel away from the ankle. Lovely. You feel the difference there? When I'm holding that down, good. Keep going. Lifting that foot up. Great. All of these things, everything that we've been doing, wringing out the foot, opening up this joint, all of this has been to get the joints of the foot to be ready for the soft tissue work that we're going to be doing from above, from the lower leg. All right, let's have a look at the soft tissue anatomy of the foot. The first thing, of course, is the plantar fascia. These wonderful 3B models here has the plantar fascia. It's a little bit of a solid thing, which of course isn't, but it allows us to see underneath. If I leave this here, because it would be on my real clients, you can see the two outside muscles here. So we have the plantar fascia, which is, this is actually too wide. In most people, it is not this 2.5 centimeters or an inch wide. It's more like 3/4 of an inch or a 1/2 inch wide, just a couple centimeters wide when it goes into the heel bone. And this has it going all the way back around the back of the heel bone, but it actually goes into, joins with the periosteum. The difficulty of these plastic models is, of course, that they have to be made out of parts, and you ain't made out of parts. So I do invite you to see the plantar fascia here, and I invite you to see what's under the plantar fascia, which we can see on this model as the short plantar flexors. But on the outside of that, you have the abductor digiti minimi and the adductor hallucis. So that these muscles are there to spread the toes wide. These muscles are here to flex the toes. You have complicated interossei and lumbricals that, the plantar interossei and the lumbricals that sit in here. We're not going to go into those in detail. We are going to say that this abductor digiti minimi that they're showing out here is supported by a fascial band, the lateral band of the plantar fascia, which doesn't show up here, but is part of this muscle and sits on the outside of the foot, and that it is also worthwhile to go along the inside. Well, let's see if we can take all these pieces off to show us this very interesting muscle that you can see on the left side of the slide, or you can see right here, which is called quadratus plantae. It's very big in this model, huge. But it is pulling the tendon of the flexor digitorum longus. It pulls it straight. It's a really interesting thing. Not very, I can't think of another example in the body, but I'm sure there is one, where because this muscle, the flexor digitorum longus, that's flexing your toes, is going to the inside of the ankle, it would pull your toes in this way. By having the quadratus plantae pulling on that tendon and pulling it towards the lateral side of the foot where the heel is, your toes are pulled relatively straight. They still come together, they still want to fold under a little bit, but they come relatively straight compared to how they would come turning your foot under if you didn't have this little muscle. So when you're working the plantar fascia and the short plantar flexors, you also could be helping to work this quadratus plantae muscle. If we take that off, we see the second layer here of the long plantar ligament connected up to these lumbricals and dorsal interossei, and then way down deep, the spring ligament. This ligament is right under the talus and prevents the foot from falling apart. So we often think of the plantar fascia as being the only thing that's holding up the arch. It's not. You've got 3 layers holding up the arch. So we often think of, and this picture depicts, the plantar fascia as being the thing that holds up the arch that as the weight is distributed. And certainly as the weight is distributed down through the body, the plantar fascia does that. But you just saw it on the model. I'd like you to see it in the picture here in a little more diagrammatic form. A would represent the plantar fascia going from the heel all the way to the heads of the metatarsals. B is the long plantar ligament, which on the model we can see right here. This long plantar ligament goes to the metatarsal bases and the cuneiforms, and that forms the second line of defense for your arches. You can work on the plantar fascia all you want. You can have as loose a plantar fascia as you want. Your long plantar ligament is still going to be holding up the inner part of your arch. But even that is not enough. You need this spring ligament, which is indicated by C there. You can see it in the diagram just under the talus, and you can imagine the whole weight of the body is coming down on the foot, bang, as you heel strike and go on to the foot. So all the weight is coming down through the tibia onto that talus. That talus would like to go right down through the foot onto the floor. Something like this. Ka-chung. But it's not allowed to because the spring ligament, which is going right from the sustentaculum tali over to the navicular, stops that talus from going down. It provides the spring, which gives you a little bit of springiness, which is a good idea, and gives that, what could we call it, a trampoline for the talus to land on and come up. If you break that spring ligament, you are really going to be in trouble with your arches, and no amount of soft tissue work is going to settle that one out. Here in this beautiful dissection by Dr. McMinn, where he cut right through the medial arch, you can see that number 10 would be the plantar fascia and the short plantar flexors that attach to it. Number 9 would be that long plantar ligament that is holding up the arch. And number 11, way up there, would be the spring ligament, or the calcaneonavicular ligament underneath the talus that acts as a spring ligament. That's number 11. So just to understand that the plantar fascia is not the only thing that supports the arches. These other structures support the arches as well. So if you look at the bottom surface of the foot here, we're going to be doing several techniques on the bottom of the foot. And it's very clear on Daphne's foot where are the limits of the plantar aponeurosis, or commonly called the plantar fascia, which goes from all 5 toes, but narrows rapidly to be this 1/2 inch or so that goes into the front of the heel. Now, if people are having a lot of pain right here, it may be a heel spur, or it may be that the place where the plantar fascia comes into the heel is been torn away a little bit. Obviously, plantar fasciitis could occur anywhere along the plantar fascia. And you can take, and notice that I'm using my fingers here to tighten the drum head, by which I mean I'm using the windlass effect to tighten, by taking her toes into hyperextension, tightening the plantar fascia so that as I work it, I'm staying with the surface. This allows me to go along the plantar fascia. I don't believe my own, that's not my own, I'm borrowing from the research of others, that it would be impossible to lengthen the plantar fascia. However, I'm combing it out. I am making it aware as possible. I am easing any knots within it, fascial densifications within the plantar aponeurosis, but I don't really believe that I'm going to lengthen it. But I am going several times, and I don't have to use my fingers as a tool. I can use my knuckles as a tool. I'm going along it from the little toe to the front of the heel. So this is the sensation-full part, yes? Yes. Okay. So, is that okay?
Yes.
Yeah. Still okay?
Yes.
Good. It's easy to overdo here not because you're actually damaging the fascias, but simply because there are so many nerves. Now, that's the plantar fascia itself. Right beside the plantar fascia on the inside is the abductor hallucis that brings the big toe towards the center line. That muscle, we can go right along that inside edge, along that muscle, right down the inner arch to the inner part of the heel bone. Right along from the ball of the foot, all the way down to the front of the heel bone. And on the lateral side, we have the abductor digiti minimi, which is the way of saying the one that pulls the little toe to the outside, and that muscle goes down the outside of the plantar fascia. So again, whichever tool I'm using, whether I'm using my fingertips, using a knuckle, or two knuckles, I'm going to end up down on the outside edge of the heel bone. But the abductor digiti minimi only goes as far as the fifth metatarsal base, and then the lateral band of the plantar fascia goes the rest of the way. And I'm going to switch feet. I'm going to have you bring this one down and this one up so that we can see this lateral band on the outside, because getting to the lateral band of the plantar fascia, it is from the fifth metatarsal base here over to the bottom of the heel bone. What I'd like you to notice is that my finger is not on the bottom of her heel. The bottom of the heel bone is here, up in the air. So maybe 1.5 centimeters, maybe a half an inch off the floor. So I'm going to catch that lateral band, and I'll trace it with my finger the first time so that you can see I'm really not down under. I'm coming in from the side and up against that lateral band. That is the way that you can get that lateral band and get some usefulness out of it. So I'm going to do that with a knuckle. I'm going to come in from the side, come up against the lateral band, and now, Daphne, I'm going to ask you to dorsiflex and lift your toes up. That's it. So lift your toes up and lift your foot up. She's stretching out from under my hand. I'm stretching back towards the heel bone, and she's hoping I'm going to stop soon, because this can be full of sensation to get that to open up. But it's really worthwhile, and as we discussed in the section on the arches, it's important whether somebody has a fallen arch, a pronated foot, or a supinated foot. In both cases, this tissue can use opening, lengthening, and resilienting, if that's a word. Make it more resilient. So we have the plantar fascia right down the middle of the foot. We have the adductor hallucis on this side and the abductor digiti minimi on this side. And that way we've got the whole foot. And if you want to have a summary motion, I wouldn't do it with her foot up in the air. In fact, I might even have something under her knee if she has hyperextended knees to soften the knee, but I can then go all the way along the bottom of the foot. and you lift your toes, the more you lift your toes, the more sensation you're going to create. So you can judge how much sensation you want or how much pressure you want to make by starting soft, and then as I go down, you lift your toes. Great. And that's okay. That's within the realm. Good. So, can you do this with a Tootsie Roller, with a ball, with some kind of SMR tool? Sure you can. The bottom of the feet is a great place to work with tools. And there's plenty of stuff to work on, so don't worry if your clients work on things between your sessions. You'll still have plenty to work on. But there's something about the human hand combing out this tissue, which in my mind works better than SMR tools. But I would say that, wouldn't I? I've been making my living that way for the last 40 years. So we've been up and down the plantar fascia, and we did this job of differentiating the metatarsal heads. But you can also take your hand and go across the metatarsal heads. What I'm using is a reinforced knuckle, one knuckle held by the other two, and going across the tops of the metatarsal heads here. Again, to open up this joint. Again, not so much of a problem in Daphne, who goes barefoot a lot and wears proper shoes, but going to be more of a trouble in those people who wear fashion shoes, cowboy boots, or other things that squish the foot this way. So I can come just proximal to the met heads. I can go just distal. In other words, I go right under the toes, and holding the tops of the toes with my hands, I can bring this tissue back. And now, Daphne, you move against me by opening your toes. You okay? Mm-hmm. Yep. Yes. Can you find that little toe too? It's in there somewhere. Yes, it is. Good. Let me just show that again. I'm holding her toes. I'm coming in beyond the toes, beyond the met heads. And she is going to open her toes while I bring the tissue over the met heads towards the plantar fascia. Yep, with all 5 of them. That's great. And with that, we're going to have plenty more for the heel, and we'll have more for the top of the foot. But there's one more on the bottom of the foot that we want to show. So what you want to do with this is make sure that your fingers are in the right place and your thumbs are in the right place on the top. And my fingers are 1, 2, 3, 4, 5, 6, boom, across the bottom of the foot. Don't come in boom, that was for special dramatic effect. What I want is my 6 fingers across the 5 met bases and my thumbs at the top of the metatarsal bases. And then I am going to squeeze in between my hands, and I'm going to lift this up. So I am taking my shoulders forward toward her head, up her body, and by doing that, I am taking my fingers out along the bottom of the foot and taking my thumbs up along the top of the foot. What I'm trying to do is unbend that joint. So this is particularly for those people who have the so-called high arch pattern, which means that actually that the metatarsals have been bent down, that the tarso-metatarsal joint is flexed, and that we're going to want to, for those people who are that high arched, but as I say, it really isn't the high arch, it's really these metatarsals being bent down, not in Daphne's foot. But we're going to show you the technique anyway. I'm going to get my fingers right at the base of the metatarsals. Well, you'll know where the base of the 5th metatarsal is. It's right here. And the base of the first one is that little bump that you run into if you run up the inside. So 1, 2, 3, 4, 5, 6 at the ends or the bases of the metatarsals. And I've got 6 fingers coming right into the bottom of the foot and really catching her tarso-metatarsal joint. And then by using my body, I bend that joint open. If I think I'm going to do it with my finger strength, you're not. It's not just a question of strength, it's a question of reaching into the body. I want not just the soft tissue on the surface to change, I want the joints to change. So I'm reaching into her body to change it. That means I'm coming up with the fingers from the bottom, down with my thumbs from the top, and then using my body to open up that joint. You will find that that technique can be repeated a number of times, either in a session or in successive sessions, so that you get what you want, which is an opening of that arch under the foot. So I'd like you to tell me when he gets the same kind of feeling on your foot that I was looking for. So here's the base of the fifth metatarsal. That's where your index finger is going to go, and you're going to have 6 fingers along the bottom of the foot, and this one's going to end up right on that bump. So this one's a little too far back, somewhere right in there. Okay, so 1, 2, 3, 4, 5, 6 on the bottom, 2 thumbs on the top. And now leaving her foot there, but you're really going to get in contact with the bones. You're really going to squeeze between your fingertips underneath and your thumbs on the top, so that you have a hold of the bones. And when you have a hold of the bones, you're going to just lean forward, and that's going to bring your fingertips toward her toes and your thumb tips toward her heel. Yes, getting the same feeling. That's the idea. Okay, good. So same goes for you guys. You have to get your fingers in there until you can feel the bones. It's easy to feel the bones on top. They're right near the top. But get the fingers into the bones, and then almost, don't use words like crowbar, do we? But it's almost like a pry bar to open those joints at the bottom of the feet. People with high arches will love you for this. The foot will come down into their shoe in a way that they can really feel. So we just showed you how to work with the plantar fascia by having the client, or in this case me, passively taking the toes into dorsiflexion or hyperextension so that the drum head is tight, i.e. the plantar aponeurosis comes into my hand, presents itself. You can even see it right there on the bottom of the foot. However, right under that are the plantar muscles, and in order to get those plantar muscles, which is really the only level of tissue you're going to be able to get to under the foot, if I now take her toes and fold them into flexion, or she relaxes her toes into flexion, yeah, you don't have to squidge them, just let them go, because then I can go under the plantar fascia, and this point I'm getting more of those short plantar flexors. And since they're more located toward the back of the foot, if I want to stretch them, when I get here, then I can gently ask her or use my own hand passively to get those toes to go into a stretch. But the trick to getting deeper in the foot is to start with the foot, with the toes especially flexed, so that I can get deeper into the foot. I'm not held out on the surface by the plantar aponeurosis. And then she goes into extension. I'm going to let you do it on your own. Go up into extension. She's saying, why would anybody do that? But for somebody who has, as she does not, high arches and a short foot, then getting into these short plantar flexors and opening them up. Now I just did that toward, we were doing a kind of pin and stretch. I was pinning them towards their origin and moving the insertion away. You can also do what would be called an active release technique of having her now go into extension and I'm going in the same direction as. Both of those work. It depends on what's going to be better for the person involved, and that involves assessing their whole structure, which is beyond what we can do in a technique.
Well, you've been very patient to get through this. Now we're getting to the meat, literally the meat of this discussion, which is how the arches are supported from above by the tendons in the lower leg. Just a reminder that the tendon action at the ankle is determined by the line of the axis of inversion-eversion, which is the line called UU in this picture from Molière, and what's happening at dorsiflexion, plantar flexion, which is the line of OO in the picture. So everything that's north of that OO line is a dorsiflexor, everything south of that OO line is a plantar flexor, everything to the left of that UU line is an inverter, or a supinator, if you prefer that term, I don't, and that everything to the outside of the UU line, to the right side in this picture of the UU line, is going to be an everter, or, again, I don't like the word, pronator. And we understand that these are all coming down from these compartments in the lower leg, so you're going to see me talk when we get into the techniques about these different compartments, and now we're individualizing the muscles in those compartments just in terms of how they support and hold up the arches. This is a wonderful thing from Grundy, just to show us how the muscles come down and support the arches in a very diagrammatic way, and it's actually quite accurate though. If we look at what is supporting the medial arch, tibialis anterior is an obvious one, coming down across the, what do we do with this? Coming down across the front of the ankle to come right here to the point of the proximal part, the base of the first metatarsal and the first cuneiform, inserting right into the joint there. Well, that's a very weak part of the medial arch, so tibialis anterior is a very strong supporter of that. Tibialis posterior, you can see it in the picture, comes around behind the ankle and, as we said before, has a very complicated tendon that also supports the arch from the inside. So these two muscles would be opposite in terms of dorsiflexion and plantar flexion, but they would be co-conspirators in, or synergists in, working together to create the inversion part of this, or to support that medial arch. Flexor digitorum longus, that we'll have more to say about later, is coming right through this canal, along the front of the foot, underneath the talus. So we said no muscle attaches to the talus, but boy, that that flexor hallucis longus tendon really goes right around behind the talus and holds that talus into the tibiotalar joint. And flexor hallucis longus goes up here, outside to the back of the fibula. The digitorum comes across and up to the tibia, so they cross underneath the foot. But flexor hallucis longus, see how it comes under the sustentaculum tali. See, that's been cut in the picture, but you see it coming around the talus, and here it would go right up along the back. So if you look, can you see the heel is offset from where the weight comes down? But guess what isn't offset? Your flexor hallucis longus tendon is right under where all the weight comes down. So the weight comes down, you go through the collapse and then reestablishment, and then when you push off, you really solidify the push from the toe all the way up the body, because it's coming in right behind the ankle joint. So here we can see the medial arch with the tibialis anterior tendon and tibialis posterior tendon. Obviously they would work together for to do supination, to turn the foot out onto its lateral edge, but they would work not so obviously oppositely in dorsiflexion and plantar flexion. Here you can see how those three muscles work together really strongly. Tibialis anterior, tibialis posterior, and flexor hallucis longus. Really strong supporters of that medial arch, which is not the best arch in the world in terms of its bone construction, but has to be the strongest arch in the world in that you go up on it, as we showed you before. You don't go up on the fourth and fifth toes, you go up on the first three toes. So it's really these tendons that are, and the strength of the muscles behind these tendons, that is supporting that medial arch. So we can talk now about the spiral line, about what holds up the arches. We already saw in the spiral line that we have this myofascial sling coming from tibialis anterior that comes down from the lower leg to the medial arch. Let me make it even more precise here. And the peroneus longus that goes through this canal behind the fibular malleolus and up to the fibular head. So you can see this sling going under that's going to support both arches, both the lateral arch. It comes right in under. I'm losing it out of its canal there, but believe me, it doesn't slip out of its canal. Going through the cuboid on the outside and coming up from the inside. It's slipped there too, but it is very strongly held up against the bottom of the foot. It's deeper than that long plantar ligament that we talked about earlier. It's not deeper than the spring ligament, but it's deeper than many, many things in the bottom of the foot to hold the arches by means of this myofascial sling that is spiral line. Tibialis anterior and peroneus longus or fibularis longus. This is called the sling. It's called the stirrup in other traditions, and it is a very strong support for the arch, but it's not the only one. So here, if we look, we can see that other muscles are used to support the arches. We can see the sling of the tibialis anterior on the lower left coming in, and the peroneus longus coming in under the whole foot there. But number 3 and number 5, the tibialis posterior and the peroneus longus, well, let me use a foot here, come in under, here's peroneus longus coming in under the foot over to here. Here's tibialis posterior coming in under the foot over to here. The two of them together are going to hold up all the arches. They're going to squeeze the foot. They're going to lift the lateral arch. They're going to lift the medial arch. And by crossing each other, they make a kind of fireman's carry underneath the arches that are really important in holding this up. So the balance of tension between the tibialis anterior and peroneus longus is important. The balance of tension between the peroneus longus and the tibialis posterior is also important. We have one more thing here, and that is the ice tongs. I think I stole that from Michael Murphy from the Rolf Institute, but who knows who he stole it from. I don't claim originality for any of my images. I am on free image stealer because I love them. Anatomical images is how I learn this stuff. If you think of tibialis anterior coming to the base of the first metatarsal, and you think of the peroneus brevis now, that would be number 4 in the slide, the two of them together coming up like this pull the 5th metatarsal base and the 1st metatarsal base into the tarsum and hold the arch together, hold the foot together. So you have the ice tongs coming down like this. In a way, I'm being diagrammatic. You have the fireman's carry under the foot like this, and you have the sling or the stirrup coming under this way. All of these balances of the muscles are very important, and you can honestly you can do a lot of work to tone, retone, and tune these muscles. And honestly, if you have somebody with weak arches, one of the best exercises you can give them is simply calf raises. Stand on a stair, keep your weight back on your heels, go all the way up till you're on your tippy toes like a ballet dancer, and then go all the way down so that your heel is below the level of the stair, and go all the way up until you're on your tippy toes. Do that really nice and slowly, one leg at a time, until you are so tired you are not going to do another one. And do that every 3 or 4 days, not every day. Your muscles need time to recover and to build their strength, but you will build the strength of the lower leg muscles by going down into dorsiflexion as far as you can, up into plantar flexion, and even up on your toes like a ballet dancer to get those toe muscles to work, and then come back down and come up again. It's a simple exercise. It's a very common exercise in workout routines. It is one of the best arch support exercises I have ever found. Let's review what we've seen here by looking at a dissection of the foot that we did several years ago so that you can see these various layers as they come in. No dissection reveals everything because every dissection has to obscure one thing to show another, but this is a very nice way of seeing all these tendons and how they come in.
Flexor hallucis brevis underneath the abductor hallucis that we already saw. In this next picture, we are now getting down to the deep front line. We see the flexor digitorum longus with the quadratus plantae off to the side pulling on the tendon. And in the next picture, we can see the flexor hallucis longus, also of the deep front line. And uniquely in this specimen, we see that the flexor hallucis longus was also going over to the small toes, making it hard for this person to flex his big toe without also flexing his little toes as well. In the next picture, if we move these long plantar tendons out of the way, we can see the oblique head of the adductor hallucis pulling the big toe to grab something between your big toe and the rest of your toes. If we move that out of the way, we see the plantar interossei, very deep muscles that work your little toes. And then finally, if we move the long plantar ligament out of the way, which actually seems to have a bit of muscle associated with it in this person, we see at the very deepest level of the foot the peroneus longus or fibularis longus tendon holding up that lateral arch and keeping the foot together. In this way, we've traveled from the very superficial part of the foot all the way to the deepest muscles.
Before we leave this subject altogether of the anatomy and go on to the techniques themselves, I want to consider two, I don't like the word pathologies, two bad usages of the foot. One of a fallen arch, a pronated foot, is really quite easy to understand. This joint turns, the whole thing collapses and comes in. However, a high arch pattern is usually not the opposite. You can have a supinated foot, and that can look like a high arch pattern. But that's not what most of the, oh, I've got high arches is looking at. They will mostly be supinated, but they will have a different pattern. The pattern that they will have is flexion in the metatarsals. We're going to show you a technique later to undo this flexion at the tarso-metatarsal joint. But look what happens. If I flex at the metatarsals and then I put this foot on the ground, it looks like, let's see if I can do this, it looks like, this is way exaggerated, obviously it would never be like this, but this looks like a high arch. But it's not a high arch, it is the metatarsals flexed down. So we'll give you a technique for opening up the bottom of this joint. That is a technique to undo this high arch pattern. And the trouble is when these guys bend down, let's see if I can make my fingers do all of this, then the toes go into a hammer toe position where they look like this. Hammer toes are not a problem of the toes. They are a problem of an insufficiency in the lumbricals. When this gets bent down, these guys can't make it that far, so you get the hammer toes sticking up. So you don't want that, but grabbing the toes and trying to get them out or doing some of the techniques that we're going to show you to ease up the toes, those are mostly for arthritic toes, not for this particular pattern. This particular pattern comes from tibialis posterior doing this. This comes from deep plantar muscles way down in the plantar surface of the foot doing this, and it involves releasing the foot and releasing the tibialis posterior muscle, which we'll show you how to do. The high arch pattern, I just really want to emphasize this one more time. The high arch pattern is not a pattern of a really high arch. I have not seen maybe one or two high arches in my whole life. It is almost always the idea of the metatarsals being flexed down. That's what you want to sort out. And the hammer toes is just the worst. That means it's been there for a long time, and the poor old toes are responding to that. It's not the toes' fault. Stop working on the toes. Work on the foot. Open it up. You'll get better results. The second common thing that you see, which is a misuse pattern, not really a pathology, but it can get pretty pathological feeling, is bunions in the foot. So what we're looking at when we're looking at bunions in the feet, it's often occasioned, as you can see in the slide, by too tight shoes. It can be really pointy cowboy boots, or lovely Italian, very pointy-toed shoes can do this. Jamming your feet into ballet slippers can do this, but you're pushing this toe off its alignment with the first metatarsal. So the first phalange, the first bone of the toe, gets out of line with the first metatarsal. So once this toe gets pushed over, it has a lot of consequences. Why? Because if we turn this over, what you have is and we're going to use this piece of string to simulate it, a tendon, the tendon of the flexor hallucis longus goes through, this is going to be hard to show, but we'll get there, goes through this canal between these two sesamoid bones. Now, most of you have grown up with plastic skeletons, where the plastic skeleton has these two bones as if it was part of this first metatarsal, but it's not. These are sesamoid bones, like your kneecap. They float in here, and they're designed, like the pillars of the temple, to create a canal through which this tendon can work. And that tendon goes right along the medial arch, as we've said before, under the sustentaculum tali, which is like a waiter holding a tray, right? If I'm the heel bone, the sustentaculum tali is reaching out and holding up the talus. Sustentaculum tali, the holder-upper of the talus. The thing is, though, oops, let's get this guy right. The thing is that the tendon goes right under that sustentaculum tali. Can you see it? Behind the talus. So at the moment that you are pushing off, this foot is so unstable that it's hard to do it. I'm going to try it with this foot. That at the moment that you are pushing off, this tendon has the weight of your whole body on it. It's called flexor hallucis longus because when I pull on it, I flex the toe. But if I write an anatomy book, it's going to be called corpus propellus forwardus because it really has the whole weight of the body on it. When it's pushing off, it is pushing off the whole weight of the body. So it has really got a tremendous amount of force. So now we stick this foot in a shoe that bends it this way, or there probably are some people with some kind of genetic tendency to this, since it does run in families, but maybe shoes run in families too, I don't know. But the idea, again, this is a plastic skeleton, so you see these two bones as if they were fixed to the first metatarsal, but they're not in reality. And if that foot is forced into the shoe and that forces that toe over, then the force every time you push off with your foot is tremendous to drive that bone farther and farther out. That's how you start to get a bunion. A lot easier to see here because this foot is loose, if we can make it work this way, that every time I step, I am driving this bone farther and farther away from the other. And it can either, I've seen both in the dissection lab when we examine people who have bunions who end up in our dissection courses. Sometimes this simply jumps out of the canal and misses both bones, or sometimes it carries this bone with it, which it can't do because it's glued on here. It's just as if it was one bone, but it wasn't. But you can imagine that tendon just simply pulling that bone along with it. both of those things happen. But once it happens, the forces are so great that it's really hard to get it to come back. Really hard to get it to come back? No, not too hard to get it to come back. If I do some therapy, I can actually get results of taking the toes that look like the lower right and making them look like the upper left. And I can do that in about an hour. And I can breathe on my fingers and say, oh, what a good therapist am I. But in point of fact, as soon as they get up and they walk out and they walk on those feet and they put the pressure back through the feet, it's going to come back to the same pattern again. And I'm not such a good therapist. There are things, the Pilates people put rubber bands between your two big toes and have you move out. There are yoga exercises of turning on your foot, wrenching the toe around. I haven't seen, there are devices that you can buy online that kind of pull your toe out. The earlier you can get to this, the more chance you have of correcting it with any one of these devices. The farther the bunions have gone, the more the joint has changed shape and the bone has changed shape. And I don't want to leave out the possibility of cure, because I believe in cure for anything, no matter how late and how long. But if in consensus reality, you have to temper your expectations and the expectations of your clients, because once a bunion has been in there for a long time, we're talking about changes in the shapes of the bones and changes in the shapes of the joint. I wish they had a better surgical solution to this than the ones that often end up in my office, but in the meantime, it's just a good thing to understand how the force of one simple muscle, the flexor hallucis longus, because it really isn't just flexor hallucis longus, it propels your whole body forward, that can create that change in the joint in the toe. You've probably done something like this or a variation of it. If I take my hand and I cup her hind foot or her heel in my hand so that it's nice and securely held between my fingertips and the ball of my hand, and then I take my other hand and I go across the tarsum of the foot, you can turn the forefoot in and the heel out, and the heel in and the forefoot out. In other words, wringing out the feet. We talked about the 28 bones. There's 14 bones in the part of the foot that I've got a hold of, and the 7 bones of the heel and the metatarsals are the ones of the tarsals, rather, is the ones that I'm really getting some motion into those joints. So this hand on the heel is going like this. The hand on the front of the foot is going like this. They're just doing it in opposite ways. In other words, my elbows come forward, my elbows go back. My elbows come forward, my elbows go back. Just to show you on the other foot, but I'll just have this foot, if you can just pick up your knee, just to have it out of the way. And I've got the heel between the ball of my thumb, between the base of my thumb and my fingertips. I've got the forefoot, and I'm wringing out the foot to open up the joints within the foot. All of these things are great openers, great ways to open up your work, your more specific work on the foot that we'll be doing later. By the way, you can come from the inside of the foot with the upper hand and the outside of the foot with the heel hand and still do the same job. I don't like it as much, but some people do. But it doesn't really matter which hand is doing what. What matters is that they're working in opposite directions to get juice flowing in this part of the foot and to make sure that there's lots of motion between all those bones. Okay, so this is a bit of a difficult technique. It's more of an osteopathic technique. Just difficult to, it's not difficult to do, it's just difficult to see. If you put your hands over the tarsals and your thumbs on the bottom of the foot. So I'm just coming at the foot like this. I'm interlocking my fingers and my thumbs are coming together under the foot.
And then I supinate. By supinating, I'm pushing her into dorsiflexion with my thumbs. My thumbs are pushing her into dorsiflexion. My hands are coming down right on the ankle. Now, for me, you'll see that even though I interlocked my little fingers end up getting out of the way, and I'm really locking with my ring finger. I don't care which finger you use, but the idea is to come right down on the talus here in front of the joint. So I'm not trying to pull this tissue above the ankle. I'm trying to get right into the ankle and pull down from there. So my thumbs underneath, my interlocked fingers on top, and then if you watch the angle of my arms, I am taking her into dorsiflexion and then giving some traction. So she's going to feel some traction in the hip, but as I move my hands down the foot, each one of these joints is being tractioned and gapped, so that I am using my hand to get a nice release of the tarsal joints here. Nobody said you can't add a little inversion, eversion, a little going back and forth across the top if you want to. But the basic thing, it isn't this. This isn't it. I'm not having her in plantar flexion and just squeezing the blood all the way down to her toes. That's not the object of the game. The object of the game is to get her into dorsiflexion, boom, connect with the leg, and then get those tarsal bones to come apart from each other. Once you get the knack, it's not a difficult technique at all. The difficulty in the technique is just getting the neck. So let's have a try at that. That's it. So just that little bit of feeling of traction, and the thumbs are coming up. And so the feeling under here, if you have any feeling left under those fingers, because I know they're tight, the feeling under here is, oh, that bone's coming away from this bone, and then this bone's coming away from this bone. It happens to be the navicular coming away from the talus, and the cuneiform's coming away from the navicular, and if you get that far, the metatarsal's coming away from the cuneiforms, but you're opening up that part of the foot. Okay, no harm in going back and getting another grip. So start again, get another grip. Push up with your thumbs and pull down, and now you can add a little bit of in and out. Again, it's just to make it easier for those joints to open up and get some distance in there. So the object of the game here is that as we come down through here, that God, your mom, Darwin, whoever you believe in, put 28 bones in your feet. And the idea is that those bones are not a rock-solid tripod on which you stump around like some invader from outer space. They're very, very adaptable devices for interacting with the real world. Now, up until 10,000 years ago, the real world had lots of rocks and sticks and bumps on the surface of the land. But we have made most of our surfaces flat, and then on top of that we put our feet inside leather coffins all day, and therefore they just don't get that adaptability. What we're trying to do here with these techniques of opening up between the toes and opening up the tarsum and opening up the plantar surface of the foot and opening up that tarso-metatarsal joint, all of these techniques are designed to get the feet feeling a little more prehensile, a little more grip on the ground, to make up for the fact that they necessarily spend a lot of time in shoes. If you're an urban dweller, or if you live where we do, where there are tons of snow just right outside this door, then you really don't want to walk around barefoot all the time. Or if you do, you're a better man than I, because I want shoes, but I also want my feet to be adaptable. And so these techniques are designed to keep the feet adaptable. Where we're going here is the end of the tibialis posterior muscle. I'm not much of a point person. I prefer working along tissues to move tissues. That's the work that I do. Not that point work isn't valuable, and this particular point is extraordinarily valuable, but you need to find it correctly. So if I get you to point your toes and then turn your foot as if you were going to look at it, you can see that tendon popping right up, right by the medial malleolus of the ankle. And if I follow that tendon down, you're really looking at the bottom of your foot. There we go. If I follow that tendon down, it comes right to the edge of the navicular bone. But where I want to go is under that. Okay, so you can relax your foot now. And I'm going to use a fingertip so that you can find out exactly where it is. If I'm way down here, that's the attachment of the tibialis anterior. She doesn't like that one either. However, the tibialis posterior is back here, right at the high point of the arch, and then a little bit under the foot. Now, I could do this with my fingertip, because I have fairly strong fingers, but I think you might find it easier with a couple of fingertips or a knuckle, in which case a hand coming down on the bottom of the foot makes it easier for you to get the leverage that you need. Now, I'm coming in under here, and if I were to really press, it would be really painful for her. So I'm going to give the client the control. So Daphne, from your hip, push down onto my finger as much as you want to and no more. That's plenty. You feel that right in there? I bet you do, because this is the end of what the Myers guy calls the deep front line. Well, you could say the deep front line goes all the way out here to the toes with the flexor hallucis longus we're going to be talking about in a little bit. But this point right here, the end, more or less the end, because the tendon is kind of like a spork, somewhere between a spoon and a fork, and it holds on to all kinds of bones down here. But this is a great place to contact, and then you push onto my hand, yes, all the way from the hip. She's doing it just right. She's not just pressing, not just plantar flexing her foot or straightening her knee. She's coming all the way from the hip, or even all the way from the rib cage down to the bottom of the deep front line right here. I don't see there's much point in having this on the camera much longer, but you can hold this point for quite a while. It reaches, you'll excuse my freshness, it reaches right up into the groin and right up into the lumbar spine from here. If you have ever seen a child with talipes equinovarus, a club foot, it is this muscle pulling right up into that deep front line that creates, or at least, I don't know if causation is a good thing, but it is coupled with that. So opening up the foot into eversion, elongating the foot from the back while you're in contact with this point is a great way to work on those people who have minor points of that kind of pattern of a supinated foot or where the foot is pulled up inside at all. Supinated, inverted, not long enough down that inside edge, as we discussed in the assessment part earlier. So find that point and really get on it. Okay, if we look at this fine plastic model of a foot here, they always make these nice, clean versions of the retinacula. The retinacula are really part of the sock that goes around the whole leg. It's called the fascia profundus, or the deep fascia. That first layer of deep fascia has some thickenings in it, just the way socks do. And these thickenings go over these tendons. And although the tendons are supposed to have tendon sheaths that they run through, this is actually much more complicated than this simple strap that they put across here and the simple strap that they show in the anatomy books. The straps are really wound around the tendons in very complex ways, and there aren't really sheaths that the tendons go through. Everything is all connected together, and if it gets too connected together, then it doesn't slide and glide properly. So this is one of the techniques that if you do it, people can really feel a difference. So Daphne, I'm going to invite you, although you're a pretty mobile person already, to dorsiflex and plantar flex as a before. This is what it's like before we do the technique. And then to move up towards that retinaculum, I'm going to start way down on her foot and move up the whole dorsum of the foot. If you remember the superficial front line anatomy we did, we're really starting at the bottom of the superficial front line and we're including the retinacula as we go along. So I've got 1, 2, 3, 4, 5, 6 fingers all in a row here. And what's missing? Can you bring your toes up? And then your foot up? And keep your toes up and step down with your foot. And then point your toes out from under my fingers. Good. And then toes up again. Good. And we'll keep this going up the leg with another technique later. We're really focusing on the dorsal surface of the foot. Go ahead and keep moving. That's good. And now down with your foot. But we're really focusing on these retinacula right here and freeing them up. Getting them nice and free all the way across the front of the ankle, all the way from the front to the malleoli of the ankle. In fact, I can even do it a second time, a little farther out to pick up the outside edge of the retinacula and move it. You may or may not feel a specific retinacula because it doesn't always look like it looks in the books or on that plastic model we were looking at. Okay, up and down with your foot. It should be easier now.
It is easier.
So we had already commented on how Daphne's toes spread apart from each other very easily. She's worked on that in her yoga. But a help for that, even for yoginis, can be to open up the channels in between the metatarsals. So this is a 1-finger job or a 2-finger job. I'm going to do it with 1 finger. Here's the first metatarsal. Here's the second metatarsal. Here's the canal in between. So I'm going up in between these. Now, that may be a little bit painful, probably not much painful to you, but it would be for some people. Can I get you to play piano with your toes as I go up these channels? So there's going to be 4 of them, right? Between the first and the second. Now I'm going up between the second and the third. Now I'm going up between the third and the fourth. And finally between the 4th and the 5th. And she is working her toes so that I can feel the muscles moving. What muscles am I working with here? The dorsal interossei and the lumbricals, and they're all involved in spreading and doing complicated motions with your toes. But opening up the canals between those bones is part of restoring the natural adaptability of the foot. We are approaching this regionally. We're looking at the legs. We're not looking at the anatomy trains as they go all through the body, but I'm the anatomy trains guy, so I want to lay out how the anatomy trains are play out in the lower leg here. We have the superficial front line. We're going to be working with that. It involves in the lower leg the muscles of the anterior calf, the tibialis anterior, and the extensors of the toes, and the sock that goes around the leg. And a significant part of that sock is the retinaculum. The rest of the sock is called the crural fascia. You'll hear me referring to the crural fascia. And it is that anterior compartment and the crural fascia that runs along the front of the tibia that I would include very much in that superficial front line. As we go to the upper leg, we're going to be working with the quads. The quadriceps muscles are very much part of the superficial front line and very much part of what we will be dealing with later in the tape. They have more effect on the knee than they do on the hip, therefore they show up in this leg's DVD rather than showing up in the hip DVD, because I don't think they have that much effect on the hip per se. However, the way that the 3
muscles come up to the hip are really worth looking at. Not all exactly part of the superficial front line, but functionally part of that superficial front line-ishness, which is the sartorius coming up on the inside, the tensor fascia lata coming up on the outside, and that rectus femoris coming right up the middle. I like this picture to isolate out these three, and I created this picture so that you could see that the front of the hip is stabilized to the outside of the knee, to the front of the knee, and to the inside of the knee. And we'll be working with that as we get later on into the techniques. Here is a picture of the superficial front line dissected. You can see the quads kind of spread out at the top, and you can see the tibialis anterior and the attendant toe extensor muscles from the bottom, but you can also see at the top left of that specimen the crural fascia as it goes in front of the tibia itself. That's not the periosteum of the tibia, that is the sock crural fascia, fascia profundus, the deep fascia that surrounds the whole lower leg and is separate from the periosteum, and we lifted it up off the periosteum. Actually, you can see a couple of places there where we couldn't lift it up off the periosteum, where there's some holes on the edge of the shin and one about halfway down. The reason those holes are there is that person, whoever it was, had an accident, fell on the stairs, kicked a tree, I don't know what happened, but through the injury, put those two fascial layers together, and then they got stuck with scar tissue, so that when we tried to lift the lower layer off the upper layer, they didn't come apart and it just made a hole. Maybe if we were better body workers or we were more delicate in our dissection, we would have been able to take them up. But I think it illustrates how injury ties fascial layers together and keeps them stuck together in terms of their function, and in this case in terms of the dissection. Now we can think about the superficial back line. The superficial back line goes from the bottom of the foot all the way around to the eyes. We're only going to concern ourselves with the lower part of it here in this tape, and that's going to be our connection from the plantar fascia and the short plantar flexors to the muscles in the superficial part of the calf, the gastrocnemius and the soleus, and you can see that that takes up the superficial posterior compartment in the lower leg, which is the lower compartment there in this picture, and that then it interdigitates, the gastrocnemius interdigitates with the hamstrings in a kind of sailor's knot at the back of the knee, as you can see here with the hamstrings, and we're going to follow those hamstrings right up to the ischial tuberosity and beyond onto the sacrotuberous ligament, and for this program that's where we're going to stop right now. Then we have the lateral line and the spiral line. We're going to deal with those together right now, but we'll be dealing with the muscles that are involved in them as we get into the specifics of the technique. But just to remind us of the anatomy trains, that lateral line involves the peroneal group, or fibulari group as they're now known, in the lower leg that you can see here in this dissection of the lateral line, and that is fascially connected right up onto the iliotibial tract, which takes us up to the iliac crest. We'll be interested in the lateral line in terms of these fibulary muscles, but also with the septa that lie either side of the fibulary muscles. And we see how those tendons go around and support the lateral arch. So we'll have things to say about in terms of the lateral line's support of the arch and the retinacula that hold those down. And that's going to take up the lateral compartment. You can see the compartments of the lower leg. The one on the bottom was taken up by the superficial back line, the one on the top by the superficial front line. The one on the lateral part is taken up by the lateral line. Very logical. We just have one more, and that's the deep front line to come in. But I'm interested in between in thinking about the spiral line. Here we see at the knee, if we look at the fibular head here, we see that we actually have a choice, what we call a switch in the anatomy trains jargon, that from the head of the fibula we can be going up and forward onto the iliotibial tract. That would be the lateral line, or we could be going up and backward onto the biceps femoris hamstring, the lateral hamstring, and that is the connection of the spiral line. You might well ask, well, how does the body know when to use the lateral line and when to use the spiral line? The body doesn't think that way in lines. Lines are just another way of us looking at the body and mapping things out. What will happen, whether it goes lateral line or spiral line, is going to depend on the physics of the situation. If your foot is planted and you are trying to make that overhand tennis shot and twisting your leg as you do so, it will go up the spiral line because that's the physics of twisting through the leg. If you are doing a triangle pose and you are leaning over to your side, then it's going to go right up the lateral line because that's the physics of the situation that's being adjusted. These lines aren't something that you think about. These lines are something that handle forces that are being sent to them. So here we see the spiral line coming down like a big jump rope from one end of the pelvis to the other. And on the left-hand side, you can see how that sling goes right under the arch. This will figure into our thinking about the rotations at the knee, but it will also come into our thinking about pronation and supination at the arch. The idea of the tibialis anterior and peroneus longus, fibularis longus, sorry, going around under the arch is a very old idea. The picture on the left is taken from my book, but I stole that picture from Clemente, who had that idea a long time ago. So the Anatomy Train's idea extends the spiral line from that sling, the tibialis anterior and the fibularis sling, all the way up to the hip. That does have implications in terms of our treatment of anterior-posterior tilt of the hip and medial or lateral rotation of the knee, as well as in the arches, and we're headed that way. I did want to show you this. This is a regular classroom skeleton, but this is the actual spiral line, the tendon of the peroneus longus connected to the tendon of the tibialis anterior, just placed in its anatomical position on the skeleton. I wanted you to see how deep that sling is. It goes right up against the bones. We'll see it in different dissection and other pictures that we're going to show you along the way. But I wanted to show you that spiral line is not something that you can touch on the surface of the foot. It is very deep under those arches. And here we can see how the back of the spiral line goes up from the fibularis muscles onto that lateral hamstring and up to the ischial tuberosity. All part of the territory that we're going to be working on here, including the fourth hamstring, which is pictured on the right. The left side of the picture shows you the long head of the biceps, the usual hamstring that everybody knows about. But underneath that are two locals, as we call them in Anatomy Train's jargon, that the biceps, the long head of the biceps would be the express that crosses both the hip and the knee. However, if we look underneath, if we could pick that up and look underneath, we would see the middle portion of adductor magnus connected up with the short head of the biceps. We'll be showing you techniques for both of those. And that fourth hamstring is really worth looking at if the regular three hamstrings, especially that lateral hamstrings, are not giving you the joy that you wanted. The short head of the biceps is especially important in rotations of the lower leg on the upper leg. Haven't got an upper leg here, but imagine rotations of the lower leg on the upper leg can be created by this short head of the biceps. Finally, we want to look at the deep front line. That's the only other line that runs through the foot this way. The deep front line is a part of what people call core, and I want to make sure that we include that. This is a dissection of the deep front line that goes all the way from the inner ankle all the way up to the tongue, and it goes up to the jaw muscles. We've done other dissections you can see on our dissection DVDs, but we're not going to cover all that. We're only going to cover the lower leg portion of it, because the upper portion of it that goes to the pelvis, the psoas, the adductors, deep lateral rotators, we're all covered on the pelvis DVD. So if we look into this deep front line, here's a wax model that was done back in the 1700s, I believe. Incredible wax models that can still be found in Florence or in Vienna. They really pulled out the deep front line. I don't know how they figured it out way back when, or why I got to write about it now and other people hadn't, but I think these ideas have been around for a long time. If we look at that deep front line in the lower leg, it takes up the deep posterior compartment. That deep posterior compartment is taken up by three muscles, Tom, Dick, and Harry: tibialis posterior, flexor digitorum longus, and flexor hallucis longus. And the "and" in between, Tom, Dick, and Harry, refers to how the tendons are going around the ankle, because that "and" is the artery and the nerve, the tibial artery and nerve that go in between. So you can find those on the ankle. We will as we move through this. But these three muscles really occupy this whole place between the tibia and the fibula, way deep in the lower leg here, underneath the soleus and gastrocnemius. So in this picture, you're seeing the soleus and gastrocnemius having been removed to show these three muscles underneath. Very tightly packed, very fascial, very much up against the back of the bones and the interosseous membrane that goes between the bones, and those muscles are part of the deep front line and very much affect the arch. So here you can see, if we take, moving from right to left, if we take the gastrocnemius and the soleus off, then we reveal these deeper muscles underneath. That's going to be relevant to our technique, because we're not going to want to press through the soleus and the gastrocnemius in order to reach these deep muscles. We're going to have to figure out a way to reach around. And this compartment idea gives us some idea of that. You can see the fascial divisions between, in this case, the transverse septum, intermuscular septum, which is the division between the superficial posterior compartment of the superficial back line and the deep posterior compartment of, sorry, but deep front line. If it's in the posterior, why do you call it the deep front line? Well, it's in the posterior in the lower leg, but it's going to be in the front by the time it gets to the spine. We can have another discussion about why that occurs. Actually, no, it's pretty easy to have that discussion right now. Your leg, we said, came out of the lumbar spine, and it comes out sideways. So this stuff used to be in the front of the leg. But as the leg turned in evolutionarily, which happened long before human beings, deer's legs and dog's legs and horse's legs all go this way, they turn in. But it takes what was in the front and puts it in the back. So that deep posterior compartment that you see deep in the leg there, the hardest one to reach, is part of the deep front line in terms of its connection all the way up the rest of the body. So access to this line is difficult, and we will be looking at that access up the inseam of the leg when we get there. And we really want to emphasize two of the muscles that are in here: flexor hallucis longus, which we'll have more to say about in a little while in this anatomy lecture in terms of its relationship to the arches and to bunions, and the tibialis posterior muscles. I love these pictures from John Hull Grundy, an anatomist long dead, I'm sorry to say, but he worked in London around World War II, and he just made these most amazing anatomical pictures. And this anatomical picture of the tendon of the tibialis posterior muscle is the best that I've seen. That's why I wanted to include it here. And as you can see, that tibialis posterior tendon is like a spork. It has connections to the heel bone, the cuboid bone, all the cuneiform bones, and the navicular, the middle three, even the middle three metatarsal bones, the talus, the bone in the cage, the only bone in the body that doesn't have muscles attached to it. That's the only part of the tarsal structure that the tibialis posterior doesn't reach. So you can imagine the tibialis posterior as a hand reaching under the arch and pulling that arch together, pulling the arch into a good, strong, locked position. We will also be looking at the pes anserinus, which is a bit of an extension. Actually, the pes anserinus is hard to get into any line, but I'm going to put it as part of the deep front line right now, just in terms of its location. But it's very superficial, but it is on the inside of the knee, connected with that medial collateral ligament, and it has to be included in our thoughts as we work up the inside of the leg.
So as we look at the lower leg, one of the things that we want to check as we're getting into doing this work is, are the tibia and fibula, specifically the fibula that you can see here on the outside, responding to the motion of the ankle? So as she goes into dorsiflexion, you remember that the wider part of the talus is getting into this joint, filling in the joint, and spreading these two apart. So I want to know, is that happening? Are the two bones spreading apart? So if I say you go ahead and dorsiflex, and it's really only going to happen right at the end, so she has to go into the full dorsiflexion, which we can either do passively, I could do it, or better, functionally, she does it. So she goes in, and what I'm interested in, I have my thumb and forefinger over the malleoli, so I'm just very gently touching the malleoli, boom, boom, gripping it like a pair of calipers so that when she goes into the dorsiflexion, I can feel whether the fibula is moving on the tibia, and it is in her case. Not much. That's why I have a very gentle touch, because these bones aren't going to move very much on each other, but I'm looking for that little bit of motion at the end. In point of fact, if you look at this motion, because of the way that the fibers are oriented, the predominance of fibers in the interosseous membrane, the fibula is actually moving out and up a little bit. But boy, if you can feel that, you're a better man than I. Most of the time you just feel as if, oh, my fingers are being slightly spread apart at the end of the motion, and that's what you're looking for. That's a responsive ankle, and that's good. The second thing I want to assess is, what is the motion of the fibula at the head end? Some people just have a suture underneath the fibula. Some people have a synovial joint. It depends on how much motion there is. I want to know how much motion there is in general. So I'm taking the lower leg, I'm holding it. I might put her foot against my chest. That kind of stabilizes it yet more. And then I'm taking the top of the fibula, which is right here, the head of the fibula, and I'm moving it back and forth. How much does it move? In this case, not much. I would expect to feel more motion. So I'm getting the motion that I wanted at the bottom of the leg. I'm not getting the motion that I want at the top of the leg. Now, I can turn this assessment into a treatment fairly easily, although the things that we're about to be doing of working all around these muscles of the lower leg will help free this motion up. But if I put my fingers right around the back of the fibular head, I have to be careful that I don't catch the peroneal nerve. So you tell me if I'm making electrical feelings down your leg, but hopefully not. Not unless I went really back in there. That would be awful. Yep. So don't go too far behind the fibula. Just go behind the fibula enough to be able to take the head and wiggle it. And that ain't enough wiggle for, given how mobile the rest of her body is, the fibula isn't very mobile. So I am going to use my third hand and stabilize her foot. Use this hand to stabilize her knee, and then take the head of the fibula, and by flexing the knee I took the tension off the iliotibial band and the hamstring, and that allows me to get some more motion into the top of the fibula. So I think you can see that I'm able to move the tibia, the head of the fibula more now in order to have. What difference does this make? The difference it makes is if she plants her foot and turns her body. If you can imagine a tennis player planting their foot and then turning to make a shot, then you would want this bone to move on the other. In fact, its lack of this motion that contributed to Tiger Woods' knee problems. So while I'm up here, I can also test the glide of the ACL and PCL, the anterior cruciate ligament and posterior cruciate ligament. So again, I'm stabilizing the foot and taking hold of the tibia and gliding the tibia under the condyles of the femur. And you can see that I have some motion here. Not as much motion as I was getting out of the fibular head. That's good, because if this slides too much, either the ACL or the PCL, most likely the ACL, is too loose. But if there's no motion at all, that's not good either. So this is just the right amount of motion. It's a good test. If you haven't learned that, it's a little hard to learn on video to get the feel of it. But again, if you do this with a bunch of people, just sit them down and move the tibia under the femur, you'll be able to tell, oh, this one has much more motion. That does not feel stable to me. Or nothing is happening, just the tibia and the femur are always moving together, in which case some of these techniques that we're going to be doing around the knee to loosen it up will be indicated. If the knee is too loose, then strengthening, not loosening, is indicated. Okay, slide down, Daphne, if you would, so far off the table. That's enough so that you can dorsiflex without hitting the end of the table. That's good, because I don't want her foot to hit the table when we're doing this technique. If you have a face hole in just the right place, she could put her face in that. But I like what she's actually doing, which is just to make a place for her nose with her hands. That way the neck can stay straight. But it's all right also if they put their neck off to one side. It is not going to affect your work down here that much. So first thing we're going to start is with the gastrocnemius and the soleus, those muscles that are heading into the Achilles tendon. So I'm going to use the whole surface of my hand here, one on each, and I'm using maybe 3 knuckles on each head of the gastrocnemius, and I'm going to lean forward over the table so that as I come down, I am half pushing, half pulling down the leg, going over the gastrocnemius heads, looking for places that are too tight and smoothing them out, like with an iron. What's missing? Her movement. So now if I can get you to dorsiflex and plantar flex. And it's uncomfy, but I'll get myself out of the way so you can see her motion. Go ahead and dorsiflex and plantar flex so that she is stretching the gastrocs out from under my hand, relaxing them under my hand, stretching them out from under my hand, relaxing under my hand. Well, now I'm down at the end of the gastroc heads here, so that's the end of that technique. Nobody would stop you from doing it a couple of times in order to get those muscles to let go. But I will tell you that most of the volume of the back of the leg is not the gastrocnemius, but the soleus. Soleus is certainly one of the most important, if not the most important, postural muscle. And it's just going to be down, it's down below the gastrocnemius, but it also goes up higher. So they overlap, both coming into the Achilles aponeurosis here. So to get into the soleus, I'm just going to have the same applicator, a great big piece of hand here, great big piece of my knuckles. By the way, I'm not making a fist, yes? My fist is never closed. It's always open. And now I'm going to go down the soleus, and again, we're going to invite you to dorsiflex and plantar flex. And again, I'm leaning way over the table so that I can fall down her leg. I just would like to illustrate the difference, but let me get through this first. I'm going to go all the way down the soleus as long as it's useful. It starts losing its use about 5 centimeters, a few inches above the ankle. So I'm going to stop there. But the soleus is a very deep. What do you mean deep? It's right here on the surface. Well, but it goes deep. It's a thick muscle so that it has depth. And I'm looking around and I'm finding, oh, there's a spot in the soleus that I really want to focus on for Daphne. So go ahead, foot up and down. And up and down, and I just keep looking through the soleus for different places that we can work. And you see that I'm using 2 hands for this, and we had 2 heads of the gastrocnemius. In my world, there are 2 heads of the soleus as well, coming down to either side of the heel. So I palpate these as differently, and just as we found this little spot out here, well, that's actually worked out, that's good, but this whole outside edge of the soleus is tighter than the inside on Daphne's right leg, so I would continue my work on what I would call the outer head of the soleus, even though the outer head and inner head are not completely separate, but functionally it's worth thinking that they are separate. Now, she gets a little thicker down here at the lower end, and I want to undensify that tissue at the lower end of the soleus. So I'm going to maintain my rapport. Now, it's harder to maintain my rapport because I can't see her eyes. So I'll just ask you to nod your head. Is this okay? Still within the bounds? Okay, and keep on going. Still okay? Mm-hmm. Yeah. Good. And that's as far as that's as deep as I need to go to get done what I need to get done, which is getting some of the thickness, dehydration, densification of the fascia, and probably some edema that is hanging out in this part of her muscle. So this would apply, obviously, to both sides. So we'll just review that quickly again of going down the gastrocnemius while she goes up and down with her foot. It's just an easy way. And then I can just continue that right on to the soleus. So the gastroc and the soleus together are called the triceps surae. I never figured out whether the plantaris comes into that or not, should though. But there's 2 heads of the gastroc and 1 of the soleus, even though I think the soleus has 2. However, we did work for the bellies of those muscles. Now we're going to go to either end. Right down at this end, you have a sheath that runs around the Achilles tendon, and that paratendon or that tendon sheath often gets more stuck than the tendon itself. You cannot lengthen the Achilles tendon with foam rolling or with any of this kind of work. It's much too tough for that. However, you can free the sheet. So if you see what I'm doing is I'm pinching the Achilles tendon. I'm starting a little bit high. I'm pinching the Achilles tendon between these 2 fingers like this. And then I'm going to invite her to dorsiflex and plantar flex, and dorsiflex and plantar flex. So I can feel the tendon or the sheet moving through my hands, and I'm holding the paratendon, the tissue on either side of the tendon, in my hands. And I'm going to carry this right down to the bone. See how we're meeting up with the 0, 45, 90? We're making it up to the top of that by opening up this tendon sheath. And it looks exactly the same on the outside as the inside, but if you want to see the inside, I'll do it on this side just so you can see. The feeling for her is that I'm pinching the tendon between my 2 hands, but I'm not pinching it very hard. It's mostly that I'm holding the tissue on the outside of the tendon, and she's moving through my hands. I am moving down her legs so that I get different parts of the tendon sheath as I move, but she's doing the motion. And I'm doing the holding to create shear between the tendon and the tendon sheath so that we get motion in there. Okay. That takes us up to the other end of the gastrocnemius soleus complex here. And this is one of the more difficult techniques that we plan to teach here. Difficult in the sense that we're going into an endangerment site, and please watch carefully what we're going to do here. I can do this as a guy if you are not so inclined to put somebody's foot on your chest for one reason or another, you can just have them hold it there. So I'll just have her hold it there for a moment. And here are the tendons of the hamstrings. Here is the biceps femoris. Here is the semitendinosus and membranosus. My fingers are going over the tendons like this. Now, what's really important about this is that I take skin with me over the tendons, and I take skin with me over the tendons, so that you can see that there's a bulge of skin between my fingers, and then I go down against the back of the femur. So I'm pressing the tops of her gastroc heads against the back of the femur, and my finger pads are against the hamstring tendons. And now, Daphne, I'm going to have you lower your lower leg slowly. And I am keeping my hands there. If anything, I'm spreading out a little bit. And when she gets down to the bottom and it's rest, we're done. So she holds her leg, or I hold the leg for her. We go over the edge and capture the top of the gastrocnemius heads, and she lowers her leg slowly. And I am, if anything, if you have a feeling, I'm going up and spreading the hamstring tendons slightly as I go. So the real thing about this technique is to bring tissue with you so that there's a bulge of tissue between my fingers, and that when I go down in, there's still a bulge of tissue between my fingers. Here's what not to do. Don't stretch the tissue and then go down in the back. You're going to be pressing on the nerve and the artery, and you could even conceivably create a Baker's cyst back there. So take lots of skin with you. Lots of skin still between my fingers. And as she lowers her leg slowly, there's still a bulge of her skin between my fingers, so that I am not pressing on the popliteal artery, vein, or nerve as it goes through the popliteal fossa behind the knee. So this idea of coming in, I'll just show you with her leg down, coming in, hooking down onto the gastrocnemius heads, and then I roll my hands out as she goes down. But I'll just say it one more time. Bring skin with you around the hamstring tendons. Don't hurt somebody in the back of the leg by stretching the skin tight, or even worse, by going straight into the middle. That's not where you want to be. You want to be underneath the hamstring tendons. And come on down. Okay, to set up this side lying work on the lateral compartment, part of the lateral line, we'll just take the leg that's closest to the table and bend that, and then put a little support in so that her knee can lie comfortably that way. Is that okay?
Yes.
So we have a few things, just let that knee bend a little bit, thank you. A few things that we can get to. We already looked at the lateral band when she was lying prone, and we came across this as part of the bottom of the foot. But obviously side lying is a way to get this. We're not talking about the peroneus brevis tendon. We're talking about the band of fascia that goes from the outside edge of the heel bone to the fifth metatarsal base. And you can go in there with fingertips for ease of the camera seeing, or knuckles for the ease of your hand, and open that up, and I'm just having her go, or taking her passively, into a toes up, foot up, dorsiflexion, toe hyperextension motion. And so this is just another way to get at that lateral band. Now, the peroneal muscles, fibulary muscles, I should say, I'm stuck in the old peroneals, but it should be fibulary by now. If you really point your foot, you might see something sticking up here. that is the soleus muscle, not the fibulari. The fibulari muscles are right up against the fibular bone, and they are so dense that they don't pop up. What pops up is the soleus behind. So if you're working on that thing that pops up, then you're not working on the right place. So to work on the fibulari muscles, it really, which direction am I going to go depends on what's happening with the arch. If she has a fallen arch and she is pronated, then these muscles are too tight and too high, and I am going to, in the case of a pronated foot, go down this way. Now you can take your foot in a circle, Daphne. Great. A little bit slower. Yep. So that's including inversion and eversion and dorsiflexion and plantar flexion in that circle. So she's getting a combination motion in there. And at some point here, I'm going from the fibularis longus to the fibularis brevis. I'm not exactly sure where. I don't really care, because in the case of a pronated foot, I want both of them to elongate down toward the foot. So this can be knuckle work. It could be fingertip work. The tool is not important. Yes, try a little bit of a bigger circle. Like you're drawing as big a circle as you can with your big toe. That's it. And then just slow it down a little bit. Thank you. And I'm going all the way along here until I run out of muscle, which is a couple of inches above 5 centimeters above the malleolus ought to do it. Good. Okay. Don't think we need to show that again, but what I do need to show is that there are walls of fascia called a septum. Septum between the soleus and the fibularis muscles on the back, and a septum between the fibularis and the tibialis anterior, or the anterior compartment muscles on the front. So we want to open up those septa. So why are we opening up these walls, these compartments between the muscles? Because anyone with compartment syndrome, no matter which compartment the syndrome is in, and I'm talking about chronic, not acute compartment syndrome, will be helped, in my experience, by opening up these two septa, no matter where the problem is, on either side of the fibulari. This one reaches back towards the back side of the fibular bone. Can you feel it? Maybe you can, maybe you can't, depends on how meaty the person is. But I'm using my fingertips to open up that septum, and I'm going to get her to dorsiflex and plantar flex to create some shear stress along this septum so that the septum opens up. And again, no matter what else I'm doing to the tibialis anterior, tibialis posterior, in the back of the knee, whatever I'm doing to relieve the compartment syndrome, I'm also going to do this, even if the pain isn't out here, because these walls are important to the compartment syndrome. Again, the direction that I'm taking it would depend on the position of the arch, as we've spoken of earlier. And so now I'm going down the one that's just in front of the fibulari muscles, in front of the peroneal muscles, and just behind the tibialis anterior and the toe extensor muscles. So I don't know if it's visible on the camera. It's being written in red here on Daphne's leg as I open up these walls to make the motion in the compartments of the leg that much easier. So we've already come up the dorsal part of the foot and into the retinaculum. And we said the retinaculum was just a thicker part of the sock anyway, so we're going into the sock of the lower leg. Now, you can carry this on up with your fingers all the way up, and Daphne, you could start dorsiflexing and plantar flexing so I get some motion under my hands. And maybe this is an easy way for you to see it on the camera. And my fingers are strong enough so that I could do this for a while, because I've been at it for a while, making my fingers strong. But for a lot of people, this would be too much for your fingers. So let's get the same territory, and when I get up to the tibial condyles, I'm just going to spread. Let's get the same territory just with the back of my hand. So I'm going to take my hands so that they look like a rooftop, so that my knuckles are together, my hands are bent a little bit, and this hand will come right into contact and conformity with the shin bone. Show it over here, so that one fist is going to be along the shin bone, and the other one is going to be with the superficial front line, or the anterior compartment. Actually, both hands are with the superficial front line, because this stuff going up the front of the tibia is part of that superficial front line. So up and down with your foot, that's great. So this is just a continuation of what we were doing on the dorsum of the foot, on the upside of the foot, and across the retinaculum, and up the shin bone, and the tibialis anterior. Now, this may look like a lot of pressure, but my pressure is up. I'm not standing up here and pressing her leg into the table. That would be uncomfortable, I bet. Okay, so if I sit down and if I drop my hands, it's almost like a sugar scoop. It's almost like scooping granola out of the bins at your local health food store, to drop the elbows and scoop the tissue up the leg. I'm getting the tissue on the front of the shin bone, and I'm getting the tissue in that anterior compartment, and I'm sending both of them up. Now you can say, why aren't you going down? And I would say most of the time, in terms of the alignment that we discussed in the first section, is that you're going to want to be going up the front. That is about a 98 or a 99% rule. There are a few exceptions where you want to go down the front of the leg, but they are few and far between. Most folks, you want to go up. Now, I do not want to cross over here to put pressure onto the kneecap. So when I get up to the top, I'm just going to stop, or I'll just show it with my knuckles here. I'm going to spread out along those tibial condyles till I'm on the medial and lateral tibial condyle. Now, that's great. But the tibialis anterior is a deep muscle, obviously, coming right down across here to a very sensitive part of the medial arch. Tibialis anterior is very important for that medial arch. And I want to be able to get the deeper part of tibialis anterior, because it goes way down here. It goes way down to the interosseous membrane, so it's a very deep muscle. Now I'm going to show it from over here, because it's going to be easier for the camera to see, but I would generally get on the same side of the table as. And I'll show you it that way in a sec. But just what I want to show you here is, here's the edge of the shin bone. No fair pressing in on the edge of the shin bone. That's uncomfortable. No need for it. I am going down beside the shin bone, and I'm going into the deeper part of the muscle. The deeper part of the tibialis anterior muscle, you have the superficial part, then you have a tendon. That tendon feels like a denser trampoline in the middle of the muscle. You may say, oh, well, that's the bottom of the muscle. No, it isn't. It's only about halfway through. And if I sink through that trampoline, I get to the deeper part of the muscle, and that's probably also a little bit uncomfortable. But too bad. That's the part that we want to open up. So now take your toe in a big circle again. Because tibialis anterior is involved with both supination and dorsiflexion. I'm having her combine dorsiflexion, plantar flexion, inversion, eversion, pronation, supination, so that I get the full motion of the muscle. And I'm going all the way down as far as I can, parallel to the shin bone. Not into the shin bone, parallel to the shin bone. Now the thing is, though, that I would usually do it on the same side of the table. So I will get myself out of the way but hopefully you can see that I now have 1, 2, 3, 4, 5, 6 knuckles going down along the shin bone. And as I go into that, you can take your leg in a circle, your foot in a circle, so that we get into the deeper part of that muscle. Otherwise, this rooftop technique that we had coming up here, that's great for the crural fascia, that's great for the superficial fascia of the lower leg, but it doesn't really get into the deeper part of the tibialis anterior. And I want to make sure that I get into that deeper part. So just so you see it from both angles, here's 1, 2, 3, 4, 5, 6 knuckles, all in a line, all butted up against that shin bone, but not pressing against it, so that I can go down parallel to it. And that is, I'm keeping my eye contact with Daphne here, because that's the superficial part of the muscle. There's the tendon part of the muscle. There's the deeper part of the muscle. Why do I care about the deeper part of the muscle? Because the deeper part of the muscle has more to do with sustaining the arch. I don't have clinical evidence for that. I just have clinical experience with that. And I get more support for the arch, more change in the arch, if I'm headed down into the deeper part of the muscle and working with that deeper part of the tibialis anterior muscle, which often doesn't get treated in regular work. Now, which direction am I going? The direction that I was just going was feeding down into a supinated foot. If I was trying to lift a pronated foot, I would still be going for the deeper part of the muscle, but I would be lifting it away from that arch, but I'd still be going for the deeper part of the muscle. I hope you can see that I'm really not straining to do this. And it's not because I'm virtuous. It is because if I use a lot of effort to get where I'm going, and you can hear it in my breathing, you can hear it in my voice, I can't feel her change. One, I'm all tied up. I'm going to be tired at the end of the day. That's number one. But that's minor compared to I can't feel if she's going to change. If I can come in here, this is the conundrum of deep work. How do I get deep without getting tight myself? How do I get deep and still stay sensitive? And the way I get deep and still stay sensitive is to ease my weight down through my bones into her body, not press via the muscles. It's a lot. She still may not say it's easy, but it's a lot easier than it would be if I were pressing in there with my muscles. So we've seen how the spiral line goes in under the arch here, and when we were working on the fibula, let's say that we were working on somebody who had a fallen arch or a pronated foot. We wanted to work down the fibulary muscles, and we wanted to work up the tibialis anterior muscle. So we can do both of those at once, and you go up and down with your foot, or take your foot in a circle, something to keep those muscles moving. And I just make sure that I'm moving down on the fibulary and up on the serratus, so that I'm giving her body the direction that we want the tissue to move as we go. So that's with the muscular sling that runs under the arch, but the same is true of the sock. In a pronated foot, the inside of the sock gets pulled down and the outside of the sock gets pulled up. In a pronated foot, that inside of that crural sock is going to be pulled down and get stuck, and the outer part will be pulled up and get stuck. So again, we're imagining that we're working with a fallen arch, so we want to feed it from the outside and lift it on the inside. So I put my fists, again, open fists, not closed fists. I put my open fists opposite each other, and I have her bring her foot up and down, and I go up and down on the inside and the outside of the leg. Up and down on the inside and the outside of the leg. You'll notice a few things about this. One is that I'm staying pretty close to my work here. That's because I want to be doing this work with my pectoral muscles. If I try to maintain proper massage position or something, and I'm going to have to do this with my arm muscles, it's going to be a lot of effort. Don't worry about getting calluses on your nose. It's okay. You can get yourself, bend at the hips, get down close to your work, and have your hands be opposite each other. So I'm up at the top of the sock on the outside, and the top of the sock on the inside, the middle of the sock on the outside, the middle of the sock on the inside, lower part of the sock on the outside, lower part of the sock on the inside. If I do this, I'm going to create a lot of shear stress. So if I was just to do this whole thing like this, that doesn't work very well. Keep your hands opposite each other as you work. And she is moving up and down. Obviously, the opposite would apply if you're talking about somebody who measures up supinated when we do the tests standing. Then the opposite would occur. If they were supinated, I would want to be lifting on the outside and dropping on the inside in order to take the foot that was too supinated and ease it into a more neutral position. Don't read people when they're lying on the table. Everybody's a supinator when they're lying on the table. But you read them when they're standing up, and then you do your work based on what you saw when they were standing up. All right, we're going to move over to this leg on Daphne so that you can see, because the deep posterior compartment, as you can see in this picture, is way down deep underneath the soleus and the gastrocnemius. So if I come in from the back trying to get to this deep posterior compartment, she will jump off the table before I get there, because I'm making Swiss cheese out of her soleus on my way to get to the deep posterior compartment. So the only place I can really feel the deep posterior compartment, which is Tom, Dick, and Harry, as you remember, we have, point your toes, the tibialis posterior tendon that we already talked about, working the end of that tendon. And then we have the flexor hallucis longus tendon, which is right along the inside edge of the plantar fascia, and then goes up behind the heel way back here along with the nerve, so I'm being careful. And then flexor digitorum, now really scrunch your toes. Flexor digitorum is coming right along there. It's a fairly small tendon and has less of an effect on the biomechanics of the foot anyway. It is really the flexor hallucis longus and the tibialis posterior that affect the foot the most. Now, to get the proper, without going through the soleus, to get this tissue into my hands, I come right around the edge of the tibia, a sharp turn. And then I go right behind the peroneals, I'll show you this on the other side, so that I am pinching the deep posterior compartment between my hands. And then again, strategy-wise, if I'm working with someone with a pronated foot, I'm going to go up the inside and down the outside. If I'm working with somebody with a supinated foot, I might go up the outside and down the inside. If I'm working with somebody with a hockey puck foot, my word for, actually I stole it from somebody, but for somebody with a really flat foot, it's not a grounded foot, it's a hockey puck foot. It goes all over the place. So in that case, I'm going to lift on both dimensions. And then there are people who are never grounded, who are totally ungrounded, and I'm going to feed the deep posterior compartment down on them. So it depends on what's going on with them as to which way I'm going to go with my hands. So this hand is going to stay. The inside hand going right up the inseam of the leg is going right up the inside edge of that tibia. Right where those muscles are up against the backside. If I could, I would reach in around to the backside of the tibia itself. And on the outside, I am going right in behind the fibulary muscles. Well, you can see the fibulary muscles. Point your toes. Right there's the tendons. So if I go in right behind them, I can feel the edge of the fibular bone. So I'm on the edge of the tibia bone on the inside, on the edge of the fibula bone on the outside, and in that way I have that deep posterior compartment between my hands under the influence of what I'm doing without disturbing the soleus, the gastrocnemius, the superficial back line in that superficial posterior compartment. Same thing applies though. Am I going down the outside and up the inside and down the outside, up with both sides, down with both sides? Depends on who I'm working on and what kind of effect I want to achieve. But this is one way to get to that deep posterior compartment. Now, when you are doing this, the same thing applies as when you were doing the crural fascia. When we were doing this with a big sweep, is I have to get down pretty close in order to be able to use my chest muscles with the work that I'm doing, rather than being up here and trying to do it with my arm muscles, which if you're vibrating, you're not doing it correctly. However, there is a way to make this a little bit easier. Let me show you. This gives you the opportunity to either work in and out with the tissue, and also for her to work with the tissue. Go up on the balls of your feet, lift your heel up. That's good. Go down now, put the heel down, lift the front of the foot up, and then put the front of the foot down, lift the heel up. And in this way I can work again, up the outside, down the inside, up the inside, down the outside, whatever direction I'm going, but I do it by working against the restraint of the yoga belt, and that makes life a little easier. Otherwise, you really do want to get down close. We can do this also, stabilizing the foot with my third hand. I can go just inside the shin bone. You see how I'm finding the shin bone and just going just inside, finding the fibula bone and going just behind, just inside of it. And now, in between my hands, I have that deep posterior compartment. So now, heel up, heel down. Good. Heel up, heel down. That's good. And just because this leg's getting red, we'll give her some. I want you to also see this on the, oh, that's awful because the little mic box is going to land on her foot. You all right? Mm-hmm. Okay, so just so you can see the inside hand, I want to show you I'm really not just going anywhere behind the tibia. I'm going to the back side of the tibia. It makes a difference how precise you are. So really right behind the tibia, right behind. I'm getting hold of that. And getting hold of its opposite on the outside. And now, without the yoga belt, I'm just using my hands. That's right. Just lift the heel and drop the heel. Lift the heel and drop the heel. Lift the heel and drop the heel. It is possible to get to this deep posterior compartment prone with the knee bent. I don't quite like it as much because it doesn't connect into the deep front line up the inner line of the leg, as well as when the leg is straight, or even when the knee is bent supine for some reason. But it is perhaps easier for the practitioner and perhaps easier for the client on the early runs. So I am getting my fingers, again, right in behind the fibula and right in behind the tibia. And now I'm going to have you take your foot in a circle. This is getting me into this deep posterior compartment. There are all these angles of approach, and I really want to make sure that we have all these angles of approach because this deep posterior compartment is underserved. People think they're getting to it by going down through the soleus. But I'll tell you, you are just going to make people crazy, and you're going to damage the soleus if you try to go through the soleus to get to this deep posterior compartment that's underneath it. That's why I want to be quite precise and quite careful about teaching you to get in behind the tibia, behind the fibula, so that we treat this deep posterior compartment separate from, which is deep front line, which is separate from this superficial posterior compartment that is superficial back line. In that way, you can really change the relationships, tibia to fibula, lower leg to ankle, and even in the foot by means of getting to these muscles in the deep posterior compartment. So if we're working with somebody whose foot is supinated, we would really want to be down into, not on, but into tibialis anterior. And now, Sampad, if you could give me a dorsiflexion, plantar flexion pattern. So he's coming up, the muscle's being used. He's going down, the muscle is relaxing, and then the muscle's being stretched as he really points his toes. And then he starts coming back up again. It starts to be worked, and then it works harder as it's coming up. So I'm adjusting my pressure depending on how the muscle underneath my hand is being used in order to open it up. And really, the tibialis anterior goes from here to here, and it goes very deep into the leg. So you can, most people feel the superficial part of the muscle and stop there. That thing that you feel, kind of like a greasy clothesline in there, is the radial pennate tendon that's in the middle of the tibialis anterior. So I want to get down past that tendon because there's muscle below it feeding into it, and that's the muscle that really affects the arch. So that's why I really want to get down deep into the tibialis anterior. There's no reason that you can't do some of these things that you would normally do prone, but you can do them supine. For instance, the weight of his leg is enough to hold the gastrocs onto my fingers so that I can comb down the backs of the legs with my fingers, looking for spots inside the gastrocnemius or below that. I'm about to get there, the soleus. So if I come right down here, just going to turn his leg so you can see where I am, but it's harder to see for the camera, but it's not a bad way for the practitioner to work. If I can relax my shoulders and just lean back, I can let my body weight do the work rather than my muscles doing the work. And looking for those places inside the triceps surae, inside the soleus. In this case, I find, oh, it's the peroneal muscles or the fibulary muscles that are presenting us with a little problem. So let's do that. Again, I don't have to turn him into side lying to do this. Once I know what I'm doing, you can approach it in the way that makes the most sense to you at the time, or if you're just going to do something short and you don't want to bother to turn the client into another position, this will work. But the object of the game is a nice, creamy lower leg that doesn't have isolated areas of tension with other isolated areas of low tone. We want an even tonus throughout the tissue of the lower leg. That works the best to distribute the strain when you're in a sports situation. And of course, it leads to the kind of postural balance that we've been looking for in this series.
That takes us up to the knee joint that I'd like to talk about the knee joint for a little bit. Obviously, Ream's books have been written about the knee joint. We're just going to have a couple of points in here. Obviously, 4 bones. The tibia underneath, the femur on top, the patella in front, and the fibula off to the side. They're all involved in the knee joint. And one way of thinking of the knee joint is it's an elbow designed by committee. Why designed by committee? Well, the elbow is a much simpler joint. If I were to put my elbow in the position of a knee, you could see that the olecranon of the elbow is pretty much like the patella.
and that my ulna is pretty much like the shin bone. And my triceps is pretty much like the quads. I have to really immediately rotate my arm to get in that position, don't I? I can't even do the right thing with my hand because they're not constructed the same. But you can see the similarity to the knee. So the patella, the kneecap, is essentially broken off, separated from the shin bone and operating separately. The quadriceps, like the triceps, comes down and attaches to that patella. The patella goes on under the knee to make, to this point, to make the knee extend. And at the same time, the rotation that you have in the lower arm is very much smaller. We've talked about it. We've worked with the fibular head, and we've looked at the ability of this to spread below, but there's not that much rotation here. So we've seen the knee has to be able to rotate, and it does when it's flexed. It can't rotate when it's extended, but it can rotate when it's flexed. And on top of that, the knee is between the two longest levers of the body, the tibia and the femur, and most of the weight of the body is coming down on it. So the elbow is a much simpler joint because it has a much simpler set of forces coming down on it. The knee gets very complicated. It's hard to work inside the knee with the kinds of techniques that we're doing. What we're doing here is simply, let's talk about the knee for a little bit, but when we get to the techniques, we're just talking about balancing the tissues around the knee. So obviously the knee is these two bones coming together, the femur coming down on top of the tibia. You can see the arrangement of the anterior and posterior cruciate ligaments here. They are actually part of the knee capsule. They're not separately inside the knee, even though you can look inside the knee like this and seemingly see them separate. They're actually a complicated winding of the capsule, but they do operate to allow the knee to go back so far and no farther. And you do not want a loose set of ligaments. And here's a test that you can use to check the tightness or looseness, particularly of the ACL, but ACL and PCL together. So while I'm up here, I can also test the glide of the ACL and PCL, the anterior cruciate ligament and posterior cruciate ligament. So again, I'm stabilizing the foot and taking hold of the tibia and gliding the tibia under the condyles of the femur. And you can see that I have some motion here, not as much motion as I was getting out of the fibular head. That's good, because if this slides too much, either the ACL or the PCL, most likely the ACL, is too loose. But if there's no motion at all, that's not good either. So this is just the right amount of motion. It's a good test. If you haven't learned that, it's a little hard to learn on video to get the feel of it. But again, if you do this with a bunch of people, just sit them down and move the tibia under the femur, you'll be able to tell, oh, this one has much more motion. That does not feel stable to me. Or nothing is happening, just the tibia and the femur are always moving together, in which case some of these techniques that we're going to be doing around the knee to loosen it up will be indicated. If the knee is too loose, then strengthening, not loosening, is indicated. If you look, obviously inside the knee, we've all heard of the menisci inside of the knee, so that we can see there's a narrower meniscus on the medial side and a wider or a larger, more open meniscus on the lateral side, because we get more motion on the lateral side than we do on the medial side. Those menisci, which could almost be considered an articular disc, except it's in two pieces inside the knee, are attached to the ACL and PCL, and also attached to the medial collateral. Well, the medial meniscus is attached to the medial collateral ligament and thus to the hamstrings, the medial hamstrings. But we can see these discs floating inside, and we can see the lateral collateral ligament is really outside this structure. It's outside the capsule of the knee, going from the condyle, the outside condyle of the femur, down to the head of the fibula. I think it's represented right here by this little piece of rubber. So whereas the medial one hugs right onto the tibial bone and comes very close to this meniscus here, the lateral one is quite far away from the capsule of the joint. I think you can see that there. And therefore is a fairly separate structure. This ligamentous capsule goes all the way around the knee, and the ligamentous capsule is very much more complicated than just the lateral collateral or medial collateral ligament. There are all kinds of ligaments bent into this, supporting the head of the fibula and joining the femur to the tibia. And I'm going to leave that for somebody else to give you the complications. I just want to make sure that we understand a little bit about the motion of the menisci when you flex the knee. So when you flex the knee, the capsules change shape so that you can see, especially that inner one, is going to change shape to accommodate the change in shape at the end of the femur, because the femoral condyle is more flat when the knee is extended, that's on the left, and it's more rounded when the knee is flexed, that's on the right. So it is the design, it is the job of the menisci to change shape. They don't do that actively with muscles, they simply do that passively under the bones, to change shape to accommodate the difference in the femur as it comes down onto the knee capsule. But there's one other thing about the knee that I just can't resist putting in here, and that is how the knee relates to synovial fluid. I don't believe that there is a joint in the body that has more cartilage than the knee. When you look at it, the femur is covered with cartilage all over its end. The whole tibial plateau is a thick piece of cartilage, and then you have these menisci floating inside as extra pieces of cartilage. So the cartilage needs to be fed, and it's not fed by the bloodstream. That's why cartilage injuries take so long to heal, as you don't have capillaries in the cartilage, because they would be squeezed every time you put pressure on the cartilage, which is what cartilage is designed to take. So the knee, again, elbow designed by committee, has a very interesting system for feeding all the cartilage in the knee. And you can see in the picture on the right what they did, what Professor McMinn did was to take the knee capsule and inject it full of green latex. So you're seeing the knee capsule blown up. I mean, it's all full. It's full of more latex than it would be full of synovial fluid. But it just makes it so clear. You can see the cove in the front. You can see that big extra bit in the front that comes up underneath the kneecap. And then you can see two extra bits, there are two extra bits, hard to see, in the back where the gastrocnemius heads are. This is such a great design because when you step forward, you're using the quads to step forward. That tightens the knee, presses down on the joint, sends the synovial fluid from the front of the joint through the joint, thus irrigating all those cartilage bits, into these coves in the back of the joint. And then when I push off the floor, I use my gastrocnemius, and that presses down on these reservoirs of synovial fluid in the back of the joint and squeezes the fluid through to the front of the joint, squeezes it up under the kneecap just in time. After the push-off, I use the quads, so I'm pressing down on the kneecap, sending the fluid to the back of the joint, and then I'm pushing off, sending the fluid to the front of the joint. It's an amazingly well-designed piece. It is designed to irrigate the cartilage with each step you take. Here's something to know. It only works with walking. When you're running, you're one, not changing the position of the knees that much, and number two, it's happening so fast that the fluid is going chuk, 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 back and forth in the joint, but not flowing through the joint as it is when people are walking. If people have knee cartilage injuries, walking is the best way to heal it. Walking actually slowly and deliberately is a great way to help. Another thing that I've used when people can't walk, if other injuries or the cartilage injuries prevents them from walking, you just take a bit of an ankle weight, on a couple of pounds is fine, and put it around the ankle, and that
drops the knee out. That puts traction on the lower leg and takes the tibial plateau away from the femur. And then you have them go through the range of motion with the knee from full extension to flexion under the table. You need to be on a table that is taller than your lower leg so that this leg is hanging freely, and you work to flex and work to extend, and do that in a nice slow way with a little bit of weight on your ankle. A good heavy shoe, a good heavy boot will be enough to do that, and that will flood the cartilage with new material, with the synovial fluid that allows that cartilage to heal. In this way, if somebody is willing to be patiently compliant and to do this exercise every day, they will help speed the healing of the cartilage, which otherwise is a very slow healing tissue. So once you get up to the knee, as you can see from this picture, we saw it before in the anatomy too, it's usually shown the quadriceps is just this tendon, just this subpatellar tendon or subpatellar ligament leading into the patella, leading into the quads. But if you do a fascial dissection, you will realize that there's a whole bridle of fascia coming down with the kneecap around the knee. So if I start just below the bridle of the knee, which means just below the condyles of the tibia, there's the edges of the condyles of the tibia, I can lift this whole bridle up. I don't want to press really hard on the sesamoid bone of the patella, but I do want to lift the bridle. So it's not just this one toe rope. There's a bridle coming out to the side, and I want to ease that bridle off, ease the side of the knee off, ease these ligaments on the knee off. If you extend out from the bridle of the knee, you can get the fascia on the side of the knee. Now, I want to be clear here that there are two pieces of connective tissue out here on the side of the knee, the iliotibial band, and just underneath and behind it, the lateral collateral ligament, which are independent of the knee capsule and very, very tough stuff. And you're unlikely to make a change in those actual structures themselves, but you are free, and it is of value to open up the tissues around them, especially coming up from that fibular head. Remember, we said we had a choice between going on to the hamstring in the spiral line or going on to the iliotibial tract in the lateral line. And so opening up around that fibular head is definitely worthwhile. I'll switch over to this side just so you can see the inside of the knee. The inside of the knee has that medial collateral ligament, which, although it's in the books, is really just part of the capsule of the knee. All of the ligaments of the knee, including the cruciate ligaments, are part of the capsule of the knee. Except the lateral collateral ligament. That's not part of it, but all of this is. So am I working on the pes anserinus or am I working on the medial collateral ligament? I'm working on them both. And in this case, I am lifting them away. There are some cases where you might want to take them toward the ground, but in most cases, you're going to be wanting to lift the inside of the knee. And that means that tissue of the pes and the tissue of the medial collateral ligament underneath it, it's especially important in the young female athletes because of the wider angle of the hips. They really press on this medial collateral ligament and sometimes create trouble there. Now, you can apply the same technique that we applied to the lower leg where we were shifting the knee up and down. You can apply that to the inside of the knee. Let me just get it so you can see it. I'll show it on both sides. Yeah, you go ahead and go up and down with your foot. I'll live. And I can shift the inner knee down and the outer knee up, or what you're going to want to do in many, many more cases is shift the inner knee up and the outer knee down, just so you see that from both sides. I'm going to turn his leg so the femur is neither
medially nor laterally rotated. Kneecap going straight towards the ceiling. And yeah, up and down with the foot is okay, but let's try up and down with the knee. Good. Well, actually what I mean is knee towards the ceiling and down. And knee up towards the ceiling, all the way up a few inches and down. And up and down. Good. A little tight in those deep lateral rotators, but we already did the pelvis one.
Cool. So that brings us through the foot, the lower leg, and the knee. We're going up into the thigh now. We're not going to cover the adductors because we already covered those in the pelvis DVDs. I hope you have those. We are going to cover those muscles that have more of an effect on the knee, which is the quadriceps, the hamstrings, and a little bit of work on the outside of the leg. But again, work with the abductors and the iliotibial band was covered in the pelvis DVD because those muscles on the inside and the outside of the thigh have more effect on the hip. The muscles on the front of the thigh and the back of the thigh have more effect on the knee. So let's take those on. When you reach above the knee and think about the quads, which are a huge set of muscles and more complicated than they first appear in the books, right above the knee is where I do a lot of assessment. Here is the rectus femoris. I can get a sense of that right above the knee. Underneath it and just medial to it is the intermedius. I get a sense of that. Out here is the lateralis, and in here, often slightly lower toned, even in this very fit gentleman. The vastus medialis often has less tone than the lateralis. So sometimes I'll be trying to ease the tone in the lateralis to match it up to the medialis, and generally lifting this tissue above the knee. That includes the articularis genu way down deep, if you could get down that deep. And I often want to not just work with these superficial vasti muscles. Well, I better finish what I'm doing there because I just went just above the knee, but we can continue that work on up the leg on either side of the rectus femoris. Vastus lateralis under my right hand that you can see. Vastus medialis, I'm doing the same thing with my left hand where you can't see. And it would look like this if I were on the opposite side. But my focus is on my outside hand because that's where the tone is too high, or comparatively high compared to the inside. I don't mean too high in an ultimate sense, but in a comparative sense. However, way down deep in here is the vastus intermedius, very underserved in the manual therapy trade. It gets worked quite well in squats, and it gets worked quite well when you're coming downhill because it operates as the brake when you're coming downhill. But to keep your upper leg from sliding off your lower leg. But you can use the flat of your elbow as an applicator and go down through the upper part of the muscle, the rectus femoris, to get down to the intermedius. Now, can you slide your knee up to the ceiling, bringing your heel along the table, and then back down, and then up, and then back down. So he's coming up into my pressure, and then coming down away from it. And I'm allowing my pressure to go through the upper layer of muscle into the deeper layer of muscle. The vastus intermedius, which is what we're going for, almost completely surrounds the femur, and it's only about 1 centimeter thick. It's not a big thick muscle, but it's a very important muscle in stabilizing your knee. You may notice that your quads are really, really tired when you have come downhill a long way. That's because that vastus intermedius is working very hard to keep your femur from sliding off your tibia.
So I like to make sure that that muscle gets worked as well. So there's lots of territory here, and we could spend a lot of time, but what we're doing is looking through here, looking for places like this one that's overly solid, and just using the bone, using the applicator in such a way that we can ease this out. Yep. And you could do several things. You could lift your knee towards the ceiling and let it come down. Yep. Sometimes people feel that, hey, I can't do that. You're coming down on me with 50 pounds of pressure. Okay. So you can press the back of your knee into the table. In other words, extend your knee and then relax. When he extends the knee, when he pushes the knee into the table, he really uses the muscle underneath my hand. When he lets his knee come forward again, it relaxes and I can get in there and get some work done. So here is the ASIS on the front of his pelvis, and there's sartorius coming in, there's tensor fasciae lata, so the rectus femoris goes into that pocket. Do you see the pocket that is created by my finger just under the ASIS? So this pocket is a great place to work. And often what you see people doing is, okay, so slowly take your foot out along the table. And what happens is that the foot jerks like this across the table, and that's not a very smooth movement. So with the purchase of a furniture slider for, I don't know, $1.89 at your local grocery store, yeah, you feel that? So don't go off the end of the table, but you can go down that far and come back, yeah? So this makes life easier for the person doing the motion. And what I'm going to do is get in on that attachment of, I'll get the other hand out of the way so you can see. So go ahead and move out. So he's moving his rectus femoris, and come on back again. Now I can work with this muscle down in the pocket, so to speak, between the sartorius and the tensor fasciae lata, working down towards the attachment, combing the attachment with my fingertips, clearing out extra stuff that gets hooked up here. All right, I'm going to take this out. You can work this very close to the bone, but it's very tight. You can see Sampat jumping when I go across it because it is, in many people, a tight muscle. So now I'm like a surfer. I'm up on top of that wave. And now my metaphor is going to go, I'm waiting for it to melt underneath my hand. But watching somebody waiting on a video is not very interesting, so we'll leave it. But I spend time here. Tensor fasciae lata, sartorius, not so important as a structural muscle, but a very important guiding muscle. Tensor fasciae lata, very important and deep muscle, and rectus femoris all come in here. All these hip flexors that need to open up in a hip opener. So I'll get this out of the way so that you can see what I'm doing with my elbow, and I'm just coming in and working. There's sartorius, there's tensor fasciae lata, and there's rectus femoris in between. So it's not very much to see here that the shift is so short from, with this being the ASIS, that's the tensor fasciae lata, that's the rectus femoris, that's the sartorius. I mean, it's an inch, a few centimeters, and I'm over all of them. But they are all hooked up to the front of the pelvis. They are all hip flexors. They all need to open in hip openers and hip extension. And hip flexion is such a common, chronic hip flexion is such a common problem that this is a great place to prepare yourself for the work that we did in the pelvis DVD on the iliacus, the psoas, the pectineus. So this is good preparatory work for that. The lateral line up here at the top of the thigh branches out like the letter Y into the tensor fascia lata on the front of the iliotibial tract and the gluteus maximus on the back of the iliotibial tract. And although we did work with both the gluteals and these little muscles under the gluteals in the pelvis DVD, I just did want to, as part of thinking about opening up the front of the hip, to come back to the tensor fascia lata as a hip flexor and as part of the deltoid of the hip, and also as a reminder that it, like the tibialis anterior, is a muscle with a superficial and a deep part. And the deep part of the tensor fascia lata, right there, already some fat is uncomfortable and hoping that I'm not really going to go there, but I am, with a heavier tool. So I come down on the tensor fascia lata and then I curve in towards the greater trochanter to get the deeper part of that muscle. Now I can put it in his hands. You can make this longer or stretch this out by lifting your knee up towards the ceiling. I wasn't exact. He is abducting to lift his knee up towards the ceiling. You can rotate your knee towards the ceiling. That's what I was looking for. Okay, wait a minute. Let me get back in here. Okay, now turn the knee up towards the ceiling. That's going to stretch this out. And he's going to wish that he wasn't turning his knee out towards the ceiling or that I would go do something else. Okay, go ahead and relax it because I'm slipping around on top of the muscle now and I don't want to be on top. I want to be in it. So here's a deeper part of the muscle. So go ahead and turn your knee towards the ceiling. That stretches this out. Okay, and go ahead and let your knee come back down. So it's resting on the blanket there. And let your knee come down again. And just rest. The other thing that you can do is take your knee back. Take your knee, your hip into extension. So your knee comes back off the table. And we're opening this up. Great. Good. So you must have lots of techniques for the gluteus maximus, and you've seen forever people going down the iliotibial tract. I don't really need to repeat that again and again. What I would like to do is the gluteus medius and minimus get underserved here. So in order to do this, I want to show you a technique for getting into the deeper parts of this. Because if you just do this, you will be held out on the superficial part of the fascia by the iliotibial tract that's going boing, boing right through there. It's supposed to be there, it's supposed to be strong. But let's see if we can get in underneath. So the way we're going to get in underneath is to passively shorten these muscles. So to passively shorten, I'm going to take his leg just below the knee, and I'm going to lean back with it. So he has to give me the leg. If he takes the, that's it. If he takes the leg, these muscles here will be contracted. But if he gives me the leg, then these muscles will relax, and I can put my elbow in between the iliac crest and the greater trochanter and come in and ease that tissue down and away. Ease that tissue down and away. And the more I can abduct the leg, the more access I'm going to have into the deeper tissues, and the more he's going to wish I would go somewhere else. It's almost not painful. It's more like, do you have to do that? It's more like, don't touch me there. It's almost a tickle, almost a pain, because these muscles don't get used enough, especially by us who are the male of the species, because we don't sashay enough. This technique is a lot easier if you do it right, so let's get it right. If I take his leg too close to the ankle, I'm going to immediately rotate his femur, and it's going to be hard to lift his leg. If I take it right at the knee, I'm going to laterally rotate the femur, and it's not going to work out well either. What I need to do is find the place, which is usually just below the knee, where if I'm lifting it, it just stays without medially rotating or laterally rotating. I need to go a little bit farther for him. Okay, then instead of lifting it with my muscles, I lift it without much muscular effort at all, just by leaning to my left. Okay, so I got his leg to go passively into abduction by just leaning to my side. Now, by leaning to my side, that means that when I bring my elbow into these tissues, it's already aimed toward his feet. If I'm doing it this way, my elbow is aimed towards his head, and I'm to dig it into those muscles there, and that's really painful, number one, and really hard on you, number two. So, don't do it that way. Just lean this way to pick up the leg, and come into... There does involve some relaxation on your part. There you go. Okay. So I have to persuade him to relax these muscles. And then I am going between the iliac crest and the greater trochanter, easing the tissue down towards the knee. Honest to whatever you believe in, this is going to be more effective than all of your trips down the iliotibial band. You'll get more out of working from here, from the muscles, from the gluteus medius, than you will doing this again and again and again, whether you're doing it with your elbow or you're doing it with a SMR fascial roller, which is all the rage these days. People are rolling out their iliotibial band. Go right ahead for all the good it will do you. But if you get into the deep gluteals, you will have a happier time with your hips and with your knee stability. So the idea here is passively shorten these muscles, get an applicator in, and ease them out towards the knee. There's really nothing for him to do. If he lifts his knee, lift your knee to the ceiling, he's going to pop me right out immediately. So if anything, you could try to pull your knee back to the other one. In other words, adduct. Pull your knees together. That passively, through reciprocal inhibition, loosens up these muscles on the outside and makes it possible for me to get in deep. By getting in deep to these muscles on the hip, you will then allow both more hip movement, but you will allow the recruitment to create more hip stability for stuff that goes from side to side. All right, let's take on a series for the hamstrings. Here's a way of warming up the hamstrings in a supine position. Then we'll be going over to techniques prone. But this is very effective if you can make it work for you. It's something that I earned from Ida Rolf way back in the day, and I still am using it these 40 years later. So come and take hold of your knee. Yep. And we're going to you're going to stay keeping hold of your knee, and your job is to pull your knee to your nose. Most people will try pulling their knee out to their shoulder. And you see how he's going out to the side, and that involves a lateral rotation of the femur. I don't want a lateral rotation of the femur. If anything, I want a slight medial rotation, so I want him to be going right towards his sternum, right towards his nose, not letting it go out to the sides. I'm going to open up the knee so that I can get right here on the hamstring tendons. I think you can see those hamstring tendons, no problem. And again, I have a big open hand, big open fist on this. And you get to pull towards your nose. I get to get in the way of the camera so that I can go down your leg like this. Please notice that I do have the other knee up. I don't want the other knee out straight. That's a lot of twist through the pelvis. So by having the other knee flexed, I reduce the strain on the pelvis. You can do this several times. I would remind you that the hamstrings don't go to the greater trochanter. The tendency when you're coming down the leg is to go out here towards the greater trochanter. That's still getting the fascia of the leg, but it's not getting the fascia of the hamstrings. The hamstrings themselves come down here to the ischial tuberosity. I will tell you, if you are working on the male of the species, they will feel, even though you're nowhere near, they will feel as if you're awfully close. So just be aware of that as you're going down the back of the leg, that the client is going to feel more exposed than they are. They are not exposed. You can't see anything, you're not going close to anything, but the feeling for the client is that you are. So this is a really effective technique for getting some initial freedom in the hamstring. And if you want to see that, take one hand on each knee and pull both knees towards your nose. And look. See how far that one is coming a lot closer to you?
Yes.
Yep. So does that left one also feel easier as well as come farther?
Yes.
Good. All right. Well, maybe we'll do your right one later to catch you up. But right now we're going to do some prone techniques for the hamstrings. So go ahead and turn on your belly. So I'm sure you have plenty of techniques for the hamstrings, but we're going to add a few more here. But rather than doing the usual ones, we'll try to do something unusual to expand your repertoire. One is that the sacrotuberous ligament is really part of the hamstrings. When I say sacrotuberous ligament, which is, by the way, right here on the inside edge of the gluteus maximus muscle, it almost feels like a bone. It's going from the ischial tuberosity to the side of the sacrum, so that thing right there. I'm not actually talking about lengthening the ligament here. If I were talking about lengthening the ligament, that would be destabilizing to the pelvis. So what we are talking about is feeding the hamstrings the tissue that runs across the surface of the sacrotuberous ligament. So once I find that sacrotuberous ligament, which I'm doing now with my elbow because it is a big, strong structure, I'm feeding it down toward the attachment of the hamstrings. But let me show you that with my fingers so that you can see it better. I am going down the sacrotuberous ligament, catching it and feeding it. Catching it and feeding it to the hamstrings, which are right here. This is just fun, you can just try bouncing a little bit on that sacrotuberous ligament to see what the response inside the pelvis is. That's getting us closer to a kind of craniosacral appreciation of the pelvis. That's not a bouncing is not a craniosacral technique, but just to the idea of how the sacrum is moving within the ligaments. However, what we're doing is just myofascially feeding down from this ligament into the hamstrings. And the hamstrings then come to the ischial tuberosity, and all three of them run together here, biceps femoris on the outside and the two semis on the inside. And I am going to come up and get to that ischial tuberosity and comb it down. Again, I'm showing you this with the elbow because it's just an easy way of saving time and energy and your fingers. But in order to see exactly what I'm doing, there's the ischial tuberosity, there are the hamstring attachments, the end of the hamstrings, hamstring tendons, upper tendons. So I'm finding and releasing them down, finding and releasing them down. So I've worked above the ischial tuberosity, I'm working on and just below the ischial tuberosity as these hamstrings come back up and attach to the backside. When you go to the anatomy books, you will find that they talk about the attachments at both ends of the muscle. So the hamstrings attach at the ischial tuberosity and they attach to the lower leg bones, but they actually have many more attachments. They have attachments north and south, like this attachment to the sacrotuberous ligament that we've just been working with, and they have attachments through the septa to the adductor muscles next to them. We'll be talking about that in a minute. And they have attachments to the gastrocnemius. This is all superficial back line stuff. And they have attachments in themselves. So here is the division between the inner and the outer hamstrings, between the semis, semitendinosus and membranosus running up the inside, and the biceps femoris running up the outside. And we know that there's plenty of separation at the bottom. We've got a full few centimeters here, 4 centimeters in between the inside and the outside. And up at the top, we know they are glommed into one glom. So my question for you is, how far up the leg are the hamstrings separate? Let's look. So Sampat, I'm going to ask you to keep your lower leg there. Now I can see those hamstrings very clearly. I put my fingers down into the separation. How far can I feel them separate? Well, actually, this young man has had some work recently, and they are quite well separated. I can go down into that valley quite well. But in order, and for a lot of your folks and a lot of your athletes, they will not be separated very well. And so now I can have him turn his foot way out, turn his foot way in, turn his foot way out. And you can see he's using the outside hamstring, and then boom, he's using the inside hamstrings. Boom, he's using the outside, and then he's using the inside. So if I stay in this valley in between the two hamstrings, and I'm going back and forth, kind of like a pendulum, kind of like a leaf falling through the water. We wouldn't use a word like saw to describe this, but we are melting the division, the septum in between the medial and the lateral. Yes, but you need to keep turning your leg all the way in and all the way out so that I can feel these muscles moving on each other, because I'm trying to open up the place so that they can have shearing movement between the medial side and the lateral side. And I can carry that up. Well, how far can I carry that up? Until there is no more division between them. Generally speaking, a few inches, however many centimeters that is, 6 or 7 centimeters down from the ischial tuberosity, you won't be able to separate them anymore. But you can create this separation up in between the hamstrings. And you could say, well, how can you work on the muscles? They're being contracted when he does this. Well, I'm not working on the muscles. I'm working on the space between the muscles, the fascia between the muscles. So it doesn't matter that the muscles are contracting on one side, contracting on the other. It's still easy for me to work in the space in between to open them up. But in Sampat's case, they were already pretty open. Now, I don't know about you, I have people coming into my practice. They are practitioners of yoga. They are able to put their palms on the floor with their knees straight. They are very, very mobile, very flexible. And yet, at the same time, they still have pain in their hamstrings. How can that be? And clearly, most of the hamstrings is very open, and thus they are able to reach the floor. But some places within that might not be so open. Here's a place within Sampat's hamstring which is not so open. So we go combing through the hamstrings, especially with those people who are very flexible but are still complaining about pain in the hamstring. There will be an island of very high tension, an island of scar tissue, an island of unresponsive tissue. You can see this is less of an island and more of a string. You can see it in his tissue there. And so having found that, I will ride it almost like a surfer. I am looking to get that place that is not combed out and to comb it out. This idea of combing I got from when I was newly a single dad, and after the manner of single dads, I was learning to brush my daughter's hair, and I took hair and brush, and the result was tears. I learned rather quickly, you don't take hair and brush, you take a little bit of hair and the brush, and that results in fewer tears. No tears at all. So I am combing the hamstrings out little by little. And the use of that word came from that idea. So I'm almost using like brush strokes or comb strokes to ease into what I found here, which is a hard, dry, unresponsive bit of tissue. And I'm going in there and opening it up. Now you notice I'm not having him move a lot, and it's easier to get these little spots when they're not moving. But once I have it pinned there, I could say, okay, now press your knee into the table and then relax back out again. Or lift your lower leg up in the air and then let it back down again. Any of these movements might be helpful in getting this thing to let go. But in terms of finding it, you want to find it when they're still, because they're easier to find and pin down. These things, when I say pin down, these little bits of tension inside the muscles of the hamstrings are highly specific and very slippery, like little mice. And you have to find and really find the very center of it, and then pin that very center of it, and then brush out the tissue to get it hydrated, to get it to be part of that working muscle again.
There is one other hamstring technique that I want to make sure that we have in here, actually two, which are of a piece, which are the fourth hamstring. The three hamstrings that we've been working with are all two joint muscles. They both cross the hip and the knee. And this one piece crosses either the hip or the knee. So we're going to work with the adductor magnus crossing the hip, and we're going to work right now with the short head of the biceps, which crosses only the knee, and is a very important postural muscle in terms of the rotation of the lower leg on the upper leg. So if we look down here, here is very clearly the iliotibial tract. You can feel that right going to the fibular head on the outside of the knee, and to the tibial condyle, and here is the hamstring tendon going to the fibular head. And the biceps femoris, obviously long head goes up to the ischial tuberosity, but the short head is under the tendon from the long head. For most people, it will be easiest to reach from outside the tendon, from lateral to the tendon this way. For some people, it's going to be easier to reach from the inside. I'm going to show you both ways. Actually, on some Pat's leg, it is easier to reach that short head of the biceps on the inside. That's more unusual. It's more usual you can get it from the outside. So come in between the hamstring tendon and the iliotibial tract, and having come in, go against the back of the femur. Now, can you do this with another tool? You could do this with your thumb, I suppose. I'm not much of a thumb worker myself, but it's not that I object to it philosophically. I just don't work very well with my thumbs. So I'm going to use my fingertips. You could use a knuckle, but make sure that you're getting past the long head onto the short head. Whatever you do to contact the tissue, what the person is then going to do, what the client is then going to do, is to straighten your knee so that your foot goes off the table towards the floor. And that pulls, this is a pin and stretch, for the short head of the biceps femoris. So come inside, well, in this case, from the outside of the tendon, up against the back of the femur, pin that tissue, and you get about halfway up the femur, for most people, is where that short head of the biceps is, and go ahead and straighten the leg. And if you get to the end, go ahead and flex it again, and straighten it again. So you can see that I've positioned him close enough to the edge of the table, so where, with a bit of support, this can go off the table easily. Before you do again, just want to show this other approach.
coming in from behind that long head tendon, can I find the short head of the biceps underneath? Yep, we can. And so now go ahead and straighten that knee again. And again, it's a pin and stretch, or you can move along it to make it more of an active release technique. Doesn't really matter, as long as you're getting in on that tissue and waking it up. But one side or the other of the long head tendon, not just pressing down on top of it. You have to go around it to get that short head underneath.
This is the second part of that fourth hamstring technique. I said I wasn't going to go into the adductors because that really is covered in the pelvis DVD. But we are going to go into the adductor magnus for this, the second part of this technique on the fourth hamstring. So I'm doing it on the opposite leg. I think you're going to be able to see it more easily over here. Here is Sampat's ischial tuberosity. So I find the ischial tuberosity. If I have him lift his whole leg, lift your whole left leg up in the air, boom, I'm going to feel those hamstrings. The hamstrings are attached as they come up here. All four of them, well, at least the three of them that come up here, are attached to the back side of the ischial tuberosity. When the client lifts their leg, you can really feel that very clearly, how the hamstrings come on to the back. But if I go just slightly forward of that, so here's where the hamstrings attach, so I'm now tucking under that hamstring attachment. Hope you can see my fingers to where I am going a little bit forward of where the hamstrings attach to the very back of the ischial tuberosity. The adductor magnus attaches to the bottom of the ischial tuberosity. Now, this is a hip extensor. So if I ask him to go into hip flexion, in other words, do an anterior tilt with your pelvis, and then come into a posterior tilt, tuck your tail under. Yep, I feel it working. And then go into an anterior tilt, I feel it stretching. Into a posterior tilt, I feel it working. And you can go down just inside. Here's the hamstrings, so I'm going right on that septum between the hamstrings and the adductor magnus. I'm going into the belly, boom, boom, you can feel it right there, of adductor magnus. It's not a hamstring, but it acts as a one-joint extensor of the hip, which makes it part of the fourth hamstring. So we are releasing this adductor magnus from the top. That feeds down this way into that short head of the biceps, comes down this way inside and kind of underneath the hamstrings to the linea aspera and links up with the short head of the biceps. So the two of them together create a fourth hamstring. So you can work the short head of the biceps with the technique that we just showed you. You can work the short head of adductor magnus, if we can call it that, the one joint extensor of the hip, by finding the hamstrings and going just in front of that on the bottom of the ischial tuberosity. If you're having trouble getting what you want out of the hamstrings, try the fourth hamstring. It's hidden underneath and it will give you good results. So now we're going to have a couple of techniques to integrate what we've done, ankle, knee, and hip. And in this case, in both cases actually, we're looking at the hinge properties of the ankle, knee, and hip. And the tendency of the knee is to not operate like a hinge and to roll in. A few people, the knee may go too far out, but for many, many people, it will roll in. So, Daphne, if I ask you to bring your knees out over your toes and we watch what happens, we can see that the left one goes more straight and the right one tends to roll in a little bit. So come on back. And I'm going to make sure that her feet are parallel, which they already are, being a good yoga student. And I'm going to put my big toes right into the front of the ankle. So I'm holding the tetrahedron of the foot. I'm holding the tripod of the foot right stable. So I can feel if she collapses in or turns out. And I'm going to reach in with my thumbs above the kneecap and just let my fingers settle around the hamstring tendons. I'm not going all the way around the back of the knee.
I'm just on the hamstring tendons, and I'm going to guide her knee. Now let's have both knees go forward, and I'm going to track her. This is called knee tracking. I'm going to track her knee over the second metatarsal, over the second toe, and I'm going to keep it over the second toe as she comes back. That's the hard part. That's where my hands really have to grip and keep her from turning this way. So to start to turn her this way, that's easy. As she bends forward, this is easy peasy. And now as she goes back, it gets harder. I keep the knee turned out over that second toe no matter what, even as she goes back into full extension. Yep. And forward again. So I'm really wanting to get her legs used to working in this way where the hinge doesn't have a rotation to it. So over the top, thumbs overlapping over the top of the patella, not pressing down on the patella, just using my hands like octopus suction cups around the whole sleeve of her leg, and she comes forward with her knee. I bring it over the second toe, and as she comes back, I keep it over the second toe, which requires some muscular strength from me to keep it going straight. And we can do this several times. I don't want her to just bend one knee at a time, or the pelvis will get a big twist in it. So it's better to do both knees even though you're only working on one. So as you come forward, keep them over the second toe. As they go back, keep them over the second toe. You'll find it's a lot easier on the way forward and more effective on the way back. So in the back, the fingers are not going all the way around to cup the whole knee and back. That would again be putting the fingers into the popliteal fossa that we don't want. I simply cross my thumbs enough in front to have my fingers hook right around the hamstring tendons. That's all I need. And then she goes back and forth, and I'm just using my hands, which are really glommed onto the whole sleeve around her knee, and I'm just using my hands to keep that knee tracking straight forward and straight back like the hinge that it's operating as in this motion. This last bit of movement is a way of coordinating the ankle, the knee, and the hip. I modified it from stuff I learned from Judith Aston, so I give her credit for the inspiration, but the mistakes are all mine. However, I've found this very useful for coordinating these hinges when I get done. Now, for this, we have to imagine, first point your toes, so you go into a plantar flex position, and then we imagine that the heel is glued to the table. In a minute, I'm going to put my finger under there, but then you won't be able to see the rest of the leg. So for the moment, just imagine that your heel is glued. And now if you dorsiflex your foot, and you flex the knee at the same time, the heel isn't moving, can you feel how you could kind of pump the knee up with the ankle? Okay, so go ahead and go down again. So you're going into a plantar flexion, knee goes straight, and I'm just going to make it easier for you. Pump the knee up with the ankle. Now you're going to have to start the knee a little bit with the muscles, but mostly this action, this dorsiflexion, will flex the knee, right? And as you go back into plantar flexion, it will go back. So as much as possible, do it again. We want the knee to stay relaxed and the action to come from the ankle. Beautiful, that's lovely. And now I'm going to ask you, I'm going to take my finger away, so you're going to imagine that that heel is still there. And I understand you're going to have to help the knee a little bit to get started, but then the ankle pumps the knee. That's it. And come down again. Good. So aside from the fact that you have to give the knee a little help at the beginning, you understand the motion. It's coming from the ankle. Makes sense to you, yes? Okay, now, as we do that, come ahead and do it again. What happens to the hip? So as we look at her hip, one of two things is going to happen. I'm going to go ASIS, PSIS with my fingers so that you can see. As she goes down, my upper finger is going a little bit forward. She's going slightly into hip flexion, and as she pumps the knee up with her ankle, she drops back. It's slight, but I hope I'll exaggerate it with my finger. She's going into a posterior tilt. The PSIS is going down, the ASIS is coming up. And as she comes down, it goes in the opposite direction. It's a small motion, so I'm exaggerating it slightly with my fingers. I hope you can see it. But that is the action that I would like to see. So I'm going to ask you to mock up the bad one, which would be go ahead and pick up your knee, but flex your hip at the same time. There you go. So if you see this, if when they lift the knee, the ASIS is going toward the knee, then you're getting hip flexion to bring this up, and that is less desirable than the other way around. And then when she lets the knee down again, it goes back into a posterior tilt. So do that again just so people can see. Ah, bad, and down. Good is the other way, so that when the knee comes up, if you can remember, now I've got you thoroughly confused because you were doing it right the first time. You don't need this as a technique. You don't need this as a cue because she's already working it such that as the front line comes up, the hip comes up and the pelvis drops back, and as the hamstrings shorten with the knee flexion, it pulls on the hip and the hip goes into, drops out at the back and comes down. That is what I would like to see with this motion. You will be surprised, however, how many people will go whoop, and the hip will go into flexion, or the pelvis will go into an anterior tilt as they do this motion. And what we want instead is, as she uses the heel to lift the knee, that this goes into a posterior tilt. So this was so you could see it on the camera. I'll do it on both sides, but I recognize I'm going to obscure the motion. But the way to do this, to get this started, because most people can't imagine that their heel will be glued to the table and they will just do this so that the heel is moving on the table. So in order to make this happen, I have them go into plantar flexion, put my finger under the heel, and then as you dorsiflex, just a little bit of assist to the knee, and then I can use my hand on the hip to make sure the hip is going in the right direction. So go ahead and back down again, and letting the hip go that way, and then come up again and letting the hip go this way. I said that I can make the right direction happen. I don't really want to make the right direction happen. I want to let it happen. So plantar flex, and I have my hand here. So now you dorsiflex, that lifts the knee lets the hip relax, and come back down again, and come up again. That's good, except that this one is more fixed than the other one. Doesn't do as much dropping, does it? Doesn't do as much motion. So now I found this interesting problem. But this interesting problem is beyond the scope of this DVD. So too bad. We're going to do this work off air, but I hope that this exercise helps you to figure out the coordination between dorsiflexion, knee flexion, hip extension. That this coordination, there, actually that's better, and going the other way, that once the brain gets a hold of this, that it becomes part of the pattern of walking, part of the pattern of sitting, and part of the pattern of functional motion, be it a squat or anything else that somebody's doing functionally. So these last two techniques, the knee tracking and this coordination among the three ankle, knee, and hip joint, are not fascial moves as such. They are coordinating moves for the nervous system, and great ways to help finish up your work and integrate it into regular functional movement. Thanks a lot. Well, here we are at the end. I hope this has been helpful to you, and I hope that you will profit both in terms of your the satisfaction of your work, and maybe also in terms of the amount of money that you're getting for your work, by incorporating these techniques and these ideas into your practice. I have zero investment that you do them exactly the way that I do. I have 100% investment that you take the ideas and use them intelligently with your clients with the patterns that they bring. I have found this work to be so useful. It's
been a very satisfying career for me to use these kinds of techniques to change people's posture, to change people the way they are in the world. I want to hark back to the very beginning of this program to say that the idea is to give people more understanding in that literal kinesiological sense of better grounding, more alignment in their legs, a feeling of being in contact in a slight prehensile way with the ground, and yet at the same time being light on your feet. It's a great privilege to be able to work with people. It's a great privilege to be able to teach you even through this medium of a DVD. So I hope you've enjoyed it, and I will just take this opportunity to plug all the other, if you like this one, we got more DVDs in this series looking at things regionally instead of in terms of the anatomy trains.
This is not a diagram of the anatomy of the pelvis, but a diagram of the forces going through the pelvis. So hopefully this can be seen against my shirt, and I'm going to just keep changing the angles. The bits that I'm hanging on to and working with are parallel to the femurs. These are like the femurs walking, and the 1, 2, 3, 4, 5, 6 horizontal ones would represent the pelvis itself. And you can see how the pelvis is responding to the leg. And the vertical one in the middle would be like the sacrum. And you can't see it on the camera, but the sacrum is slightly turning this way and this way, as the sacrum does in real walking, so that we're modeling in tensegrity there what we're modeling in a very small model here, and what we're hoping to see in a real human model here in a little bit. This kind of motion.
Thanks, good luck, and good skill.